होगा मेरे सब जगह तो ना कर देगा मजे मजे लगा नहीं आता ಹೆಚ್ಚು ಟೈಮ್ ಕರ ಹೆಚ್ಚಿಗೆ ಮತ್ತು ಮದುವೆ ಹೆಚ್ಚು ಟೈಮ್ ಕರ यूट्यूब लिंक था देखा सब करा ना मुझे हाँ करा मैं मुंडा था मुंडा था मैं बोले ध्यान है Abi sordu. Bir bağlı bir saat yarın ya bak.
Prima quando mi pare io sono protetto più per di per volte di famiglia.
Good evening, everyone. I am Dr. Ramindra Senarathne, Joint Secretary of Sri Lanka Association of Minimal Access and Digital Surgeons. It is with great pleasure that I welcome all of you gathered here today for the joint CME session organized by the Slamads, Alsgbi, and Amasi. The challenges we face in modern surgical care require us to continually update our knowledge and skills. And this joint CME session presents an opportunity for us to do just that. We are honored to have with us today President of the College of Surgeons of Sri Lanka, Professor Nandadeva Samarasekara. Professor Samarasekara has been unwavering in his pursuit of excellence in surgical practice and training. I welcome you, sir. I extend a warm welcome to all our international faculty members who have joined us today from various parts of the world, despite their very busy schedules. We are privileged to have such an accomplished group of experts in the field of minimal access surgery. On behalf of the Slamads, I welcome with great honor Professor C. Palanivelu, founder president of Amasi and a pioneer in the field of laparoscopic surgery. His contributions to the advancement of minimal access surgery are truly remarkable. I would also like to extend a special welcome to Professor Tan Arulampalam, President-elect, ALSGBI, Professor C. Selvasekar, Professor Y.K.S. Vishwanath, Mr. S. Khadir Kamanathan, and Mr. Altaf Awan, who are renowned experts in their own fields. We are honored to have such an esteemed faculty members from the United Kingdom joining us for this session, and we are excited to collaborate with you and learn from your expertise. We also welcome our brethren from India who have always stood by us, Dr. C.J. Varghese, President, Amasi, Dr. Kalpesh Jani, Dr. P. Senthil Nathan, and Dr. R.V. Patankar. Your wealth of experience and innovation will undoubtedly enrich our discussions. And I would like to extend my sincerest welcome to all of you. I hope that you find this session informative, thought-provoking, and enjoyable. And I also welcome people who have gathered in our regional centers in Kandy and Jaffna. Without further ado, I invite Professor Bhavanta Gamage, President of Slamads, to address you and begin the proceedings.
Thank you very much, Ramindra. Good evening to everyone who are present on site today, as well as all our international delegates, as well as the international faculty and the members of our sister associations, Association of Minimal Access Surgeons of India and Association of Laparoscopic Surgeons of Great Britain and Ireland. Thank you very much for joining with us today. We started Sri Lanka Association of Minimal Access and Digital Surgeons of Sri Lanka with an objective of improving minimal access surgery in Sri Lanka, ensuring patient safety. I think the other objective of our association is to get all the medical professionals who practice minimal access surgery into one platform, because through that platform, we believe that we can improve the quality of care that we give to our people. Because of COVID pandemic and the economic crisis we have been going through, our activities little bit subsided over the last 2 years, I would say. However, the development of IT facilities, development of online teaching and educational activities during this pandemic made us this platform today, so that without reducing the quality of education, we can now get the experts sitting all around the world who are willing to share their knowledge with us into one platform, and we all can share our knowledges and experiences. We got this thought in December last year when we met Amasi executive committee members in Mumbai when we attended the ASICON 2022. And then we had a brief discussion with Alsgbi, and all of them are quite happy and willingly giving their hands to us to organize this session. So let me thank all the executive committee members and all the faculty members who have given fullest support to organize this event. So without further delay, I would like to invite, and at the same time, I would like to thank the College of Surgeons of Sri Lanka. We are all part and parcel of it, who has given these premises to us to conduct this session. So let me first invite Professor Nandadeva Samarasekara, President of the College of Surgeons of Sri Lanka, to address the gathering. Over to you, sir.
Thank you, Bhavanta. Dear all, on behalf of the College of Surgeons of Sri Lanka, it's my pleasure to welcome all of you present here and other colleagues who have joined us online. First of all, I must thank Professor Bhavanta Gamage, who is a leading laparoscopic surgeon in Sri Lanka, for organizing this excellent event. I'm also very grateful to all our overseas faculty members for helping us to make this event a success, namely Mr. Tan Arulampalam, who has even been a trainer of most of our surgeons who are working in Sri Lanka, Mr. Altaf Awan, Mr. Sri Kadiragamanathan, one of our own people, who was here actually a few days back, and I'm sure he would have taken a little bit of sunshine back to the United Kingdom from here. And Professor Sekhar, Professor Vishwanath, a well-known great man, a minimally access surgeon, Professor Palanivelu, Dr. Wagis, Dr. Kalpesh Jani, Dr. Patankar, P. Senthil Kumar, and also all our local faculty for arranging, who have arranged this workshop. Dear friends, we have a very distinguished panel of speakers today, and please make the maximum of their expertise. And I must say, without much ado, I wish to hand over the proceedings to Bhavanta, and I wish all of you all a very, very fruitful meeting today. Thank you.
Now I invite Professor C. Palanivelu to address the gathering.
Friends, good evening. And I'm delighted to be part of this inaugural program of CME cum workshops, jointly by Sri Lankan Association of Minimum Access Surgery, College of Sri Lankan, and also Alsgbi, an Association of Laparoscopic Society of Great Britain, Ireland, and Amasi, for all jointly making this program wonderful program. In fact, I feel I'm not there personally, but I wish the program should go well, and I'm sure the organizers have taken a great effort making it. And now Samasagar has spoken, and Tan is there. Arulampalam is also waiting. Varghese, President of Amasi, all of us making this program happiness. And Amasi is always will be part and parcel of friends in Sri Lanka. And since starting from, I still remember that the way the first program and went from General Hospital, Bandaranagar General Hospital, long time back, more than 25 years. It is very nice from that time. I'm always cherished for taking part personally or otherwise all the time, online at least. So this program made it colorectal, bariatric, and upper GI, HPB, all part of this program, well programmed, and good number of faculties are there. Also from India, Rai Patankar, Kalpesh, all of them are part of this. And I'm happy that next program, I love to be there and personally to make it. And I wish every one of you the best of luck. Long time I've seen Tan, and today he's on the line. I love to see them. An Association of Laparoscopists of Great Britain and England, where I'm also an honorary member, and very nice that way he's promoting minimal surgery across Sri Lanka and other countries. And recently also we were at Mauritius. He was there as personally participating in it, promoting minimal surgery. And every year I'm seeing College of Sri Lanka and Minimal Surgery of Sri Lanka always make it a wonderful program. And always hospitality is wonderful. And friendship is growing year by year with both countries, Sri Lanka and here. I wish it continue. Thank you very much. I will part of this. Thank you very much making me part of this inaugural program. Thanks.
Thank you very much, sir.
Yeah.
Now I kindly invite Dr. C.J. Varghese, President Amasi,
Thank you.
to address the gathering.
Greetings from Amasi. As the President of Association of Minimal Access Surgeons of India, and on behalf of the association, I would like to express our sincere thanks for making Amasi a part of today's CME program, along with Sri Lanka Association of Minimal Access and Digital Surgeons, and also with the Association of Laparoscopic Surgeons of Great Britain and Ireland. Our congratulations to Dr. Bhavanta, the President of Sri Lankan Association, for conducting this joint academic event. Amasi, the association from India, is represented for today's program by our founder president, Professor C. Palanivelu, and by our eminent faculties, Dr. Kalpesh Jani, and Dr. Roy Patangar, and Dr. P. Sendilnathan. Amasi acknowledges the presence of Professor Tan, the President-elect of Association of Laparoscopic Surgeons of Great Britain and Ireland. This is the first joint venture between the two associations, and we look forward to many such events in the coming days. Amasi acknowledges Professor Nandadevas, the President of College of Surgeons of Sri Lanka, Dr. Ramendra, the Secretary of Association of Minimal Access and Digital Surgery of Sri Lanka, and other distinguished faculties present here today, and also the senior surgeons and the delegates attending today's program. Amasi is an organization with more than 12,000 members and with a focus on minimal access surgery. The association is conducting various academic events and also the charity programs around the year, like CMEs, live surgical workshops, online education programs, skill development programs, and various other activities. We also conduct the training sessions on different areas of minimal access surgery at our training center in Chennai. We are happy to extend our services to all those who are in need of this support from both inside as well as the outside the country. Once again, we take this opportunity to thank Dr. Bhavanta and Sri Lankan Association of Minimal Access and Digital Surgeons for the invitation, and let us together spread minimal access surgery in this region of South Asia and beyond this region also to more and more surgeons and the trainees for the benefit of the patients. Best wishes from Amasi for today's CME program. Thank you.
Thank you very much, sir. Now I kindly invite Professor Tan Arulampalam, who is the President-elect of the Alsgbi, to address the gathering.
Thank you very much, and thank you to Professor Bhavanta Gamage. I had the pleasure and joy of working with Bhavanta many years ago and it's a real honor to be able to see how far surgery has come in the country of my birth, and what a contribution Bhavantha has made, but how he has brought together so many incredible surgeons in Sri Lanka, and today bringing together Amasi and Alsgbi to put together this educational program. So Bhavantha, huge congratulations. This is quite humbling to be part of all of this, and I'm sure that Alsgbi will be very keen to work with Amasi. We thank Professor Varghese for that lovely introduction, and I'm sure that we will be able to have some fruitful discussions today and make it the beginning of, I hope, a collaboration that will see our younger surgeons make surgery even better. This is, for me, just the beginning. Thank you very much for inviting me to take part, and I know that my colleagues from the Alsgbi are very keen to continue this participation. Thank you very much.
Thank you very much, sir. Now to start the proceedings of the main event tonight, I would like to kindly invite Professor Bhavantha Gamage to moderate the session on colorectal surgery. And I warmly welcome Professor C. Selvasekar,
Hello, thank you. Thanks very much. Thanks very much for the invitation.
Dr. Kalpesh Jani,
Thank you very much for this invitation.
Professor Bhavantha Gamage, over to you.
Good evening, everybody. Let me invite the local panelists, Dr. Rasita Manatunga and Dr. Rukman Sanjeeva to the head table. So we are starting the case discussion with the colorectal case. So I'm going to present the case, and we will allocate 10 minutes at the end of this discussion for the questions from the audience. So let me ask the audience to send your questions to the chat box. So we will be answering the questions at the towards the end of the session. So I'm going to present the case, and in between we will stop and we'll get the opinion and the questions answered by the panelists. So our patient is a 41-year-old lady who presented with rectal bleeding with mucus, and colonoscopy done has shown a growth in the rectosigmoid junction at 15 centimeters, extended up to 20 centimeters, long sessile component and proximal polypoidal component. The histology taken at the colonoscopy revealed adenomatous polyp with severe dysplasia. Though there is no definite invasion, the possibility of adenocarcinoma cannot be excluded in the histology. I hope you can see, this is the endo view of the tumor. This was done in August 2020. And the CT scan done at that time, unfortunately, we do not have the pictures to show you. There was a irregular circumferential growth seen in the distal sigmoid colon involving a length of 4.8 centimeters. There is moderate luminal narrowing. No proximal bowel dilatation to suggest obstruction. Fat stranding outside the wall was there, suggestive of local infiltration. A few lymph nodes in the adjacent mesentery, the largest was 6.2 millimeters of suspicious nature. The CEA was done at that time was 90, and she had no family history of any bowel cancers. So let me ask from Tan Arulampalam. Tan, what do you think if this patient come across at your clinic? What would be the plan of management?
Thank you, Bhavanta. So the most important thing that I tell my trainees is that decisions are more important than incisions. So this case must be discussed in a colorectal multidisciplinary team meeting. So from the story you've given me, the patient has symptoms, rectal bleeding with mucus. The colonoscopy has shown a suspicious lesion, and the histology showing severe high-grade dysplasia may be a sample artifact, and one has to take the view that there could be a malignancy underlying this. The CT scan, interestingly, is very suggestive of a cancer. Now, in my experience, and I'd really like to hear the opinions of the rest of the panel, but these distal sigmoid tumors tend to behave like rectal cancers. And what I mean is their outcomes tend to be much poorer because we don't stage them properly. And it's my practice that all of these patients get an MRI, actually, in the distal sigmoid. So that's one thing that I would do. The CEA obviously is raised. So this person is heading towards some sort of radical treatment. And for me, the one piece that's missing from the case that's presented is that I would have an MRI to properly delineate the adjacent structures. But from the information that you've given me, I would be considering speaking to the oncologists, talking about neoadjuvant therapy, and of course, for me, the MRI would make the big difference there.
Thank you, Sekha. Any addition to that from European point of view? Is there anything that you want to add into Tan's suggestion?
No, I completely agree with what Tan has said. Depending upon what the scan is like, then sometimes we ask for an MRI scan. Certainly in a male, we would ask for an MRI scan. In female, sometimes depending upon what it is like on the cross-sectional imaging, we may just decide that is enough of imaging. It is not within the bowel wall, because looking at your CT report, there is extension outside. I would be looking at more, is there any radiological evidence of EMVI? And then discuss at the MDT to decide on what the management options are. Here, I would traditionally we used to sort of go in and take these out, but nowadays there is more evidence coming through where there's evidence of neoadjuvant systemic treatment first, followed by surgery. Same as what Tana said would be my approach. Thank you.
Okay. Kalpesh, hope you can hear us.
Yeah, I can hear you. Am I
okay.
audible? Yeah.
So what would you do from this part of the world? You know,
Right.
we have the, sometimes our peripheral surgeons may not have access to sophisticated investigation. So if you come across this patient, what is your plan?
Yeah. For rectal cancers, I think pelvic MRI is the imaging modality before you are going to plan any sort of surgery. CT scan, in this CT scan itself, when it says it's a sigmoid tumor, you have to remember these tumors tend to infiltrate a lot submucosally. So it should be considered and treated as a rectal cancer. On the CT itself, it's showing that it's infiltrated to the surface, and there's a suspicious 6 millimeter node which radiologically appears suspicious. So then basically this is a clinically, locally advanced, clinically suspicious, something like, I would say clinically T3 and one sort of tumor, clinical T3 and I would probably, once I get the pelvic MRI done, and the protocol over here is to get a chest abdominal CT and a pelvic MRI, along with, of course, this thing. You have very high CEA, again, that points towards locally advanced growth. So probably I would, insist on trying to get a biopsy confirmation of malignancy, and then would like to push the patient for a neoadjuvant, total neoadjuvant sort of therapy before, planning. If I get the malignancy confirmation, then before planning for surgery upfront.
But this is a sigmoid tumor. So
I would say lower sigmoid rectal, upper rectal tumor. It's just borderline. On the CT, it's showing as a very lower sigmoid. It's just 11 centimeters from the anal verge. I'm sure if you had MRI would have shown infiltration into the rectum. So I believe that probably these should be treated as upper rectal tumors rather than sigmoid tumors.
okay. So let me direct the questions to local panelists. What is our plan here? Rasita.
I think we have, we have no, working. Yeah, we have now exception. We investigate in the same line. MRI is, yes, of course, yes, it's in the guidelines, but unfortunately we don't have MRI facilities freely. So what we do is we do the CT scan, and we get unfortunately we can't see the pictures here. If it is in the sagittal film, if it is above the pelvic brim, we wouldn't go for a MRI because most of the centers we don't have MRI. Otherwise, if it is below, we would do MRI. In addition to that, as Jani pointed out, I would probably do a rear biopsy here because we don't have confirmed malignancy. So that's something I would probably do. Apart from that, I mean, the line of investigation would be the same.
If I might just make a point that that's exactly the problem with CT, that it tends to underestimate the T tumor size factor. That's why pelvic MRI has come to be more sensitive for this lower sigmoid rectal tumors rather than CT scan. But then, of course, depends on the local resources available, as you very correctly pointed out.
So if I can just add to this, the point you've just made is important. We're all here to learn, and Gina Brown has published a lot of work on these distal sigmoid tumors, and I think this is the balance, because if you have the Buck-Rogers effect, if you understage this tumor, the patient will be back. Yes. Taking up more of your resource because they have been given treatment appropriate for condition A when actually they have got condition B. So you can get completely blindsided. So this sort of case, depending on the numbers, you need to consider if there's worth investment in infrastructure, which I realize there's a resource issue. The only other point I'd make in this lady, she's 41. If the resources are available, when you do the rebiopsy, I would do some molecular markers, which is important for planning treatment. And I think the patient has to be counseled that this is likely to be a malignancy.
Okay. Our oncology team did not want to give neoadjuvant treatment, of course. Because of the CT findings and the clinical evidence, the surgeons decided to do open sigmoid colectomy. This was in November 2020. And the histology came as moderately differentiated adenocarcinoma, tumor size 75 into 25 into 20 millimeters. It was infiltrating muscularis propria, but not into the pericolic fat. No lymphovascular invasion was detected. Circumferential margin, proximal and distal margins were clear. And it was saying it was Duke's A tumor. 28 lymph nodes were taken out and all were negative. And then the oncologist did not want to give adjuvant treatment. So what is the next step? What would you do next?
But Bhavanta, before you move on, can I ask why the patient had an open operation? I realize it was November in the middle of the pandemic. Were there concerns?
Sorry, Tan, I didn't hear you properly.
Why did the patient have an open operation?
Oh yeah, that is another point of discussion. This patient was treated in a peripheral hospital where the laparoscopic facility was not developed. So still in this part of the world, and the open surgery is taking place. So that is why she underwent open sigmoid colectomy.
Okay, understand.
So what is the, now here, what about, these are the questions I would like to discuss. Young onset colorectal cancer. How common the disease in this part of the world? What is your experience, Sekar?
Thanks very much. We say it's around 2%. When you look at colorectal cancer in 40s and 30s. The problem is there's usually a delay in diagnosing these patients. They're usually treated as hemorrhoids, and they present late, and their disease is more aggressive. And that is where the genetic testing comes in. All the patients, all colorectal cancers now have a microsatellite instability testing done. In this patient, it looks like she's not had it, but that is what we would do as a standard. But would we do anything different based on the histology? I think we would just be following her up with the regular sort of scans as per the standard protocol. It's a Duke's A stage 1 disease. Although the CT showed there was extension beyond, it looks like from the histology, it's probably inflammation rather than the tumor, which has caused that sort of a radiological finding. Apart from the genetic testing, apart from looking for microsatellite instability, there's not much we would do differently. Looking at the role of neoadjuvant treatment, I've got some slides which I'm happy to share. I think that is certainly an area which is growing rapidly, and we at the Christie are seeing huge benefits. I'm sure colleagues have seen this article from Memorial Sloan Kettering Center, where there was complete response in a significant number of patients, and since then there's been a lot of evidence on that. So that is something which we can probably discuss, but I'll leave that with you.
We will come to that. Kalpesh, what do you think in India? How common young colorectal cancer? What is the prevalence? Is it same as?
We are definitely seeing young colorectal cancer, and I agree with what Sekar said, that if you see a young patient with colorectal cancer, the alarm bells start ringing, because these are the patients, even though if they are detected early in stage, they are going to be quite aggressive. Very often, we are now seeing colorectal cancer occurring even in teenagers, and those are typically, when you do a biopsy, it comes as a mucinous adenocarcinoma or signet ring carcinoma. Those are extremely aggressive. Even if you operated, they may be just stage 1 or 2, but then they'll end up very soon with distant metastasis, and they go on for chemotherapy and systemic therapy, second line and all that. So younger cancer patients are definitely being seen, and they are typically very aggressive cancers. So we like to nowadays, counsel the patients, warn them beforehand that because the emotional fallout associated with colorectal cancer in young patients is going to be much, much higher than if you are, have treating the same sort of stage cancer in a 70, 75-year-old male. And especially in a private practice with the current scenario, that leads to a lot of consequences. So you have to be very upfront with the counseling part. You have to spend time with the family. You have to warn them to not get too optimistic. Don't show them the roses that, that will operate and will clear everything out and patient will be all right and all that. You have to be very guarded in your prognosis.
What is your experience in Sri Lanka, Rasita? Is it more common, or when you
in
compare
general,
to Western
colorectal
world?
cancer incidences are very rapidly increasing in our country. Now, 2019 cancer registry, now colorectal cancers are the third commonest in our country, both in men and women, which was not the scenario 10 years ago. In 2010, colorectal cancers were still third in men, but seventh in women. So we see a lot of new patients. And also, we don't have, data with us, but in practice, we see a lot of young patients coming with colorectal cancers. These are happening all over the world.
Okay. Tan, what is your opinion about neoadjuvant treatment in colon cancers? Is it well established now, a well established scenario, or is it still in evolution? What is the evidence?
Yeah, so this is something that is still, there's lots of evidence to show that neoadjuvant treatment has some benefits, that there are obviously downsides, but it's certainly not mainstream in terms of practice. I think
yeah.
Sorry. So I certainly wouldn't say in colon cancer neoadjuvant treatment would be the way to go. I think one of the points that's come up repeatedly is that there is a real drive towards these distal sigmoid tumors. They do behave as rectal cancers. I think I'd like to pick up on another point about the age of the patient. We've seen, and if you go onto the Cancer Research UK website, you can see, and the Bowel Cancer UK website, you can see that the age of patients developing bowel cancer is definitely changing. So certainly in the age group of the 30s, we've seen a huge rise. If you look at people who develop cancer who were born in the 1990s, they're 4 times more likely to have rectal cancer. So the pattern, as well as the disease, is changing. So that's 4 times more likely than somebody of the age of 70, for example. And there was a very interesting point made about the histology. These tend to be mucinous signet ring type cancers that are very, very difficult to treat. They're very, very bad prognosis. So it's really important that the counseling to the patient and their relatives and the subsequent support is really excellent. It's a very, very difficult problem that we have to be much more aware of. So the public needs awareness of the disease, so to present with if they get symptoms, and also the education of primary care doctors.
Thank you. Kalpesh, how do you follow these patients after surgery in India? What is
Yeah, so the typical protocol, most of us follow the NCCN guidelines and protocol. The typical protocol is that you, for the first 2 years, you call the patients somewhere every 3 or 4 months for a clinical exam, a digital rectal exam and a proctoscopy. You do a CEA every 3 months, follow up with a CEA. Colonoscopy 6 monthly for the first 3 years, and an MRI or a CT scan every 6 monthly for the first 3 years. Then it's yearly after that for the next 5 years.
Okay. Sekar, what is the follow-up plan in UK? Supposing the patient has had full colonoscopy as in this patient, and after surgery, what is your follow-up plan?
Yeah, it's something similar to the NCCN guidelines. We do a scan 6 monthly for the first 3 years, and this is a young
CT
patient.
Scan.
CT scan, sorry. Yeah, CT, chest, abdomen, and pelvis. And we would do a colonoscopy in 3 years, and then 5 yearly after that. And that is also changing because there is, once someone reaches, at the moment it is between 50 and 60, depending upon where you are, that they're getting a fit test done. And then we put them in that screening program. In this lady, I would be interested to know what the CEA is, because that is a marker. She has, it was elevated to 90 before. So that will be certainly used as a marker each time she comes to the clinic for a clinical follow-up, which will be 6 monthly in the first year and then yearly after that.
Okay. And now we were talking about CEA. What is the role of CEA in follow-up? Kalpesh, what is now this patient's CEA is pre-op CEA level was 90, and
yes. So CEA has several. There are some papers which have also come up showing that CEA may have some prognosis marker. It may be a prognostic factor also. Extremely high CEA is above 60, 70. That means that the patient already has a systemic disease. This thing, but still that's not a universally accepted thing. But mainly CEA, what is accepted about CEA is that it's useful in follow-up. So if you have a high CEA or before surgery, after the treatment is over, the CEA has to drop to normal. That shows that you know that the treatment was successful, and then you follow up with CEA. And if you find a CEA, a regular pattern, whether for 3 months or 4 months, 6 monthly, you have whatever is the pattern at your institute, you find that the CEA has risen in one particular follow-up instance. It's not that the next day itself you start doing the workup. You again call the patient for the next scheduled follow-up after 3 months. So repeat the CEA. The CEA has shown consecutive rising trend over 2 follow-ups. Typically, at our points, if in our clinics, if we get a higher CEA in follow-up, we ask the patient to come back again immediately after 3 months, do a repeat CEA. If it has again risen beyond the first CEA, then we do an extensive workup, including, if required, a PET-CT to find out if the patient has developed some distal or local recurrence. So it will start off with a full colonoscopy, and we'll go right up to a PET-CT.
Let me ask from Sanjeev, what do you think about CEA value in this patient, and what is our plan in follow-up with CEA?
So the first initial CEA was very high, and that case it's important to because the patient's at the biopsy came as severe dysplasia. The malignancy was not confirmed. So in that case, if we see that sort of scenario, the first thing is to either repeat the biopsy. So then we can decide on neoadjuvant treatment if it is confirmed malignancy. And then in the follow-up,
this is the follow-up CEAs.
Yeah,
I'm just
putting
Let's come down.
The first thing is if it drops to the normal, and so initial within the 4 to 6 month period, once you see the CEA remaining within the normal range, then standard the follow-up protocol is planned.
Yeah. So in Sri Lanka, most of the time we do ultrasound scans of the abdomen and pelvis in follow-up. So this patient also had 3-monthly ultrasound as well as CEA levels. And as you can see, CEA came down initially, and it went down till April 2021. And in January 2022, patient had normal colonoscopy, and anastomosis was looking healthy. But in July 2022, patient CEA started rising, and it was further rising by August. And then August 2022, patient developed symptoms of PR bleeding. So what would you do next at this point, Sanjeeva?
Yeah. So in clinically now the patients the symptom of PR bleeding need investigating. So the first thing is if the patient hasn't had the colonoscopy, need to be done.
Yeah, he had a colonoscopy in January 2022, and in August he has developed rectal bleeding.
Yeah, with the still with the rising CEA and the PR bleeding, the first thing is to look inside, because you can have either recurrence or this is 2 years down the line, so you can have a new cancer developing. So both has to be excluded as a safe measure.
Yes. So the patient moved into the center of the country, and patient had CECT chest, abdomen, and pelvis in August. And there was an area of wall thickening and enhancement in the anterior wall of the mid-rectum at 9 centimeters from the anal verge, mild luminal narrowing with minimal fat stranding. It raises the possibility of tumor recurrence rather than a post-surgical changes. So this was the CT scan finding. And the surgeon did flexible sigmoidoscopy. Anastomosis was visualized at 7 centimeters, and there was an ulcerated area with contact bleeding immediately distal to the anastomosis. So he suspected probable tumor recurrence. What would you do next, Tan, in this patient? The biopsy was taken, and during the waiting time, what would you do?
So you now have a situation that's progressed. You've got a CT scan in a patient who's had a rapid onset of a recurrence. Now, what I would first do is obviously speak to the patient, but I would want to review that histology to make sure there's nothing that we missed, because it was classified as a Dukes A tumor. The second thing is I would, if the resources permit, I would consider a PET CT scan to make sure that there is no multifocal disease. Even if it's oligometastatic, you may change how you approach the next phase of treatment. And then you have to assess how you're going to go forward. Again, talking to the oncologists and surgical colleagues, because anything that you're going to do surgically now is going to be highly invasive, high risk, and you want to make sure that you get it right first time. So summary of that is, in my practice, I would consider a PET CT and make sure that the whole of the, I see some things coming up in the chat, absolutely right. We need to do a full colonoscopy to make sure the whole colon is visualized.
Kalpesh, what would you do? Would you change Tan's plan, or do you have the same plan of management?
No, same plan of management, because now again, we need definitely a tissue diagnosis of malignancy. We need to, this is already advanced disease. So once it's recurrent, it's advanced disease. So we need to look for metachronous metastasis, whichever way you want, either a CT scan or a PET-CT at least. And start exploring. Once we have the biopsy, I would probably ask, along with the biopsy in these cases, now I would be looking at the other tissue markers also, not only that MSI. If it's MSI has not been done, I would ask the pathologist to do it. And if possible, like over here, it's what we ask is we ask the RAS, NRAS, KRAS, BRAF, and HER2 amplification markers also, because that gives options to the oncologist to plan the oncotherapy if required. Because this is now an advanced stage. It's not a localized disease, it's a systemic disease already now.
Okay. What would you do, Rasita, in Sri Lanka?
I have a little concern whether it's really a recurrence or a metachronous lesion for a couple of reasons. One thing, if you get the original histology of the first surgery, it's quite early tumor. It's a Dukes A, T1, N0, and the circumferential resection margin was very clear. And even the distal resection margin, which is about 3.5, I suppose. So in that case, to have a local recurrence is bit unlikely. It's not impossible. So my mind, there is a possibility of metachronous lesion as well. But whatever it is, the management wouldn't change. We have to restate the patient and then probably discuss in the MDT and take from there.
For trainees' point of view, Sekar, what is for sigmoid colon tumors? What would be the length of distal resection margin you would look at? Is it what is the length you will clear distally and proximally?
Well, yeah, well, I think here you had enough the margins, at least from the slides what you have put in. It is a decent specimen length. Ideally, we would look for anything more than 5 centimeters is what we would look for. It is an R0 resection in the first place. What I would like to know is, you say the anastomosis at 7 centimeters, ulcerated area with contact bleeding. Was it separate from the anastomosis or was it at the site of anastomosis? And the second thing is, in this case, certainly we would get an MRI scan because, it is going to decide on the next steps. So an MRI scan is certainly something which we would ask for. And just a clarification on the scope, it will be a colonoscopy is what we would ask as well, just to make sure there is no other polyps or lesions in the rest of the bowel.
Yes. So the anastomosis was at 7 centimeters, and the surgeon did sigmoidoscopy and took the biopsies. And in the waiting time, he requested MRI, rectal cancer protocol. Luckily, we have got now well-trained radiologists here. Few of them were trained in Royal Marsden under Gina Brown. So we do standard protocol MRIs. So the biopsy of the flexible sigmoidoscope came as highly suggestive of recurrent adenocarcinoma. The MRI showed local recurrence at the anastomotic site. It's a T2, N0, MX. CRM was potentially involved anteriorly. EMVI negative, pelvic side walls were negative. So what would you do for this patient, Kalpesh?
Yeah.
The colonoscopy was also, other than this lesion, it was negative elsewhere.
So just to be on the safe side, I would also, as I said, I would like to see also look at the distant metastasis, whether PET-CT, if possible, I would like to get it done. Definitely get it done to find out if there are any distant metastasis. And secondly, I would like to know from the biopsy, what was the grading, histological grade, whether it was well differentiated, poorly differentiated tumor.
Moderately differentiated.
Moderately differentiated, right? So yeah, this patient definitely is going to require re-resection at least. If in the absence of any distal metastasis, but you have a potentially involved anterior margin. So probably I would, in this cases now, I would think of, starting a new adjuvant therapy for the patient.
Sanjeev, what do you think in Sri Lanka we will do?
Yeah, definitely this patient need resection. But before that, one thing is this is a recurrence tumor and the potentially involved margin. So this patient obviously need, because the patient had already surgery, patient need chemoradiotherapy. Though it is adjuvant or for the next operation, we can call it as, again, neoadjuvant. So patient need definitely chemoradiotherapy before the whatever the intervention. And one more thing I have to highlight, as Mr. Arulampalam said, the patient need the PET CT, but it's extremely difficult to get a PET CT organized in this part of the world, in Sri Lanka.
Yeah. So the question, do you call it TAN, or Seka and Kalpesh, you can comment. Do you call now, if you give chemoradiotherapy, do you call it adjuvant or neoadjuvant in this scenario?
No, I would now we are treating a fresh recurrence. So I would still go with a new adjuvant, because now that would clarify what we are doing with the tumor that is now present at present.
Yeah, so, I would agree. This is a fresh tumor, as it were, a new event from the index event. So you're giving neoadjuvant treatment.
Yeah. So patient had, sorry, Kalpesh.
No, it wasn't me.
Yeah. So this patient had, after the MDT discussion, long course chemoradiotherapy, completed in October 2022. Then restaging MRI was done, and then had laparoscopic redo anterior resection and defunctioning ileostomy in February 2023. Now, what is the waiting time in UK after neoadjuvant treatment for rectal cancer? I mean, how long you wait before the operation? TAN.
So, thank you. So for the last 20 or so years, my practice has been to wait for 12 weeks. And we've got some data on that. It's going to be a horrible field to operate on. The anastomotic leak rate can be up to 20% if you are able to get it back together again. On occasions, we've waited even longer than 12 weeks. I think one has to be very careful about when you operate, and also what operation you do, because of that danger of an anastomotic leak. And in this person, if I do an anterior resection, it looks like it's possible. I would definitely do a defunctioning loop ileostomy. I would definitely ensure that they had gut selective decontamination of their bowel, and I would ensure that they had all their risk factors for anastomotic leak optimized, because the cost of an anastomotic leak to the patient is catastrophic. The financial cost is 40,000-50,000 euro, and they end up being in hospital for so long with enteroatmospheric fistulae, hernias, all of those things. So the short answer to your question is I would wait 12 weeks minimum.
Kalpesh, what would you do? Would you?
Yeah, I think that practice in India is a little different. Most of the people that I know is echo. We usually wait around 6 to 8 weeks. We operate by around somewhere between 6 to 8 weeks after the end of the last radiotherapy.
Seka, will you wait 12 weeks or will you go for 6 weeks?
No, we would certainly wait, because there is certainly evidence to suggest that there is tumor regression beyond 6 to 8 weeks. So we would certainly wait for 12 weeks and then do an MRI scan, so you know what you're dealing with, and then we would operate. I would say that you've been a bit brave to do a redo anti-resection and a loop defunctioning ileostomy in this patient, because this is a patient who's got recurrence and the anastomosis is 7 centimeters from the verge. Functionally, there may be issues. I'm not saying there will be, and in a woman, it is something which we would counsel this patient well, and to the discussion what Tan made about the anastomotic leak. I think the priority in this patient is to make sure that the cancer is treated optimally so that we don't see her in a year or two with the recurrence, because pelvic recurrence is a huge problem, and so that is the approach we would be taking.
Can I just add to that, Seika? I think those are really wise words. I think one has to think about what are you trying to achieve in this lady? You want cancer clearance. That's number one. She's really young, and what you don't want to do is also make her life miserable. And I think the point you make about function, particularly after radiotherapy, I think you're being kind. I think the function will be pretty poor, and I think those two things have to be taken into account when you're counseling the patient as to how they proceed.
Okay. Rasita, what do you think about the plan of management?
Yeah, number one, the timing of surgery. Knowing the tumor regression is more when you wait longer, 12 weeks. But the surgery is going to be quite difficult because of fibrosis after radiotherapy. So we do the surgery around 6 to 8 weeks. And second thing is around the ileostomy. I would take on-table decision. So if I'm quite happy with the resection as well as the anastomosis, I wouldn't go for a defunctioning ileostomy. Otherwise, I would.
Yeah, but the factors that we have to consider is the age of the patient and the fact that patient has had radiotherapy. As Rasita says, we have to take the decision on the table, but we have to consider the risk of anastomotic leak in this type of patient. When would you do MRI scan after the neoadjuvant treatment? What is the timing of second MRI before the surgery? Now we operate around 10 to 12 weeks. When would you do the MRI after the neoadjuvant, Seika?
We would do it around 10 weeks, Bhavanta. We have had experience of doing it in 8 weeks, and we've gone in and find that you're taking rectum out, which is there's a lot of inflammation, and also you probably gone in too early. So we would get a scan in 10 weeks and repeat our discussion at the MDT, and then decide on the need for the next step. In small percentage of patients where it is a very close margin, when we are not sure about how the response is going to be, we would scan at 4 weeks, 4 to 6 weeks. The reason for that is there's a selected group of patients, especially the young ones with mucinous tumors, who don't respond well to radiotherapy. And if the margin is closed, you need to do something. You can't just leave them for 10 weeks, in which case you may miss the opportunity to do something salvage surgery. So we would do that. And if they're responding, if they're showing signs that there's a response, then we would repeat it with a further MRI in 10 weeks. But at the same time, if there is no response, then we would take that as a chance to just get in and do the surgery, because there's a lot for them to lose by just waiting for 10 weeks.
Just to add to that, Bhavanta, our routine practice at Colchester is we do an MRI at between 4 to 6 weeks. So that is done precisely for the reasons you mentioned, Seika. And that small group we can then try and salvage, but they're almost a self-selecting group of very, very poor responders. Then we repeat the MRI at 10 weeks. which I think is helpful because you really have a good roadmap. There are some patients that we see after neoadjuvant chemoradiotherapy at this point, and everything has resolved. There's quite a lot of fibrosis, but then you see these lakes of mucin. And when you do the resection, the patient actually has no tumor. They have these lakes of mucin. So that's important. What we're seeing here, we've had one case of a patient sue, so take litigation, because their tumor responded completely and there was no cancer in the specimen. So we're now facing a very difficult decision as surgeons and as MDTs about making those choices of how to proceed. So I think all the information is important. I'd just like to also make a point about intraoperative decision-making about defunctioning loop ileostomy. I think it is a really difficult decision because I think all of us experienced surgeons have had anastomotic leaks in patients who've had perfectly looking anastomoses. I currently do an ICG test. I currently do a flexible sigmoidoscopy of all my anastomoses. That's been shown to reduce the anastomotic leak by 50% just by looking at the anastomosis with a flexiscope. So those two things are very useful. But the only thing I do know is that when we audited our data from 2003, we found that we had an anastomotic leak rate in these patients of just over 20%. And I don't think we're particularly bad surgeons. I think if you look across the literature, the rates of leak are high. So I would, defunctioning loop ileostomies do have their own problems, but I would counsel extreme caution in making that decision. It's one of the decisions that I find most difficult.
Okay, so the histology came as moderately differentiated adenocarcinoma, no tumor perforation, budding or lymphovascular invasion was absent. Tumor excision complete and margins uninvolved. Proximal margin was 25 centimeters, distal margin was 3.5 centimeters, and distal donut, no abnormality was seen. So histologically, they gave us T2, NX, MX. There were no lymph nodes in the specimen. I think because of the previous surgery, I think 28 lymph nodes were harvested. So this was the histology. Now the question is, how are you going to follow this patient up? What is the plan of follow-up? And before that, what are the measures you take to make sure that the chances of anastomotic leak is going to be less? Is there any precautions you take, Kalpesh, other than your meticulous resection?
Yes. So basically, what Tan mentioned was that doing the ICG test just as you're doing the anastomosis, that's one of the good ways of ensuring that you have a well vascularized anastomosis. Of course, checking for the technical issues like checking for the complete donuts and is also important. The other thing is, again, in all the patients, exactly as what the surgeon has done in this case, all patients who have had any sort of radiotherapy in the preoperative session, I would always add a defunctioning ileostomy, because typically our patients, as compared and this, I believe this is very typical of our patients, that they're very poor protein reserves, and they handle leaks very not as well as perhaps it would be seen in patients in the Western side. So leak is a much major complication for us with a very significant mortality involved along with, our patients most of our patients can't afford total parenteral nutrition and all that. So I would rather err on the side of safety and put in a diverting ileostomy in all my patients. So these are some of the things that you can do to, reduce the chances of a leak, and if it leak happens, to reduce the consequences, severity of the consequences.
Will the defunctioning ileostomy itself reduces the anastomotic leak?
No. But at least, as I said, this reduces the severity of the consequences of the leak.
Any thoughts, Chan? Will the defunctioning ileostomy, because I have seen some trainees think that defunctioning ileostomy will reduce the risk of anastomotic leaks.
Yes. So this is really interesting. I used to always teach that the defunctioning loop ileostomy will not prevent the anastomotic leak. And there is some interesting work from Holland that has shown that in those patients that have a defunctioning loop, their anastomotic leak rate is reduced. So I think it needs further study, but I think we have to take anastomotic leak seriously, because otherwise the treatment is worse than the disease. So in my practice, I'm really cautious with the defunctioning loop ileostomy, but in this sort of patient, I will much more veer towards fashioning an ileostomy. The problem is we find across this country that most of the surgeons will use heuristics. They'll do a defunctioning loop ileostomy because they feel that that's the right thing, and not based on any objective risk factors. And of course, if a patient is a smoker, diabetic, obese, and had radiotherapy, they are going to leak. That's my experience. So I think we have to be really cautious. We owe it to our patients, and it's important for any trainees listening that caution will pay off. And you know, we know that the incisional hernia rate is 15% when you reverse these ileostomies. We know that you can get renal failure. So we have to mitigate for that problem and cater for it, because it does have an important effect. So if you're asking me, do they reduce anastomotic leak? I would say they possibly do, and they certainly make the effects much less.
Okay, thank you. Now the take-home message is your meticulous resection, ICG, yes, but of course we don't have that facility here in Sri Lanka all over. Rasita, any or Sanjeev, any other things you would do to minimize the risk of anastomosis?
Yeah, in this particular case, because the patient already had a resection and we are doing the recurrence, there will be a problem with the length. So the tension has to be considered at the anastomotic site. So you should not think twice to get the full, sometimes the transverse colon mobilized to get a tension-free anastomosis here. And then the other thing is obviously the blood supply. So should not get the ischemia around the proximal end when you do the especially previous surgeon must have taken the IMA. So so has to be very vigilant and concerned about the blood supply at the proximal end.
Yes, that's very important point, and I'm opening up another wide area. We believe now anastomotic leak is infective. What is your opinion about preoperative antibiotics? Tan and Sekar, do you practice that? And I want quick answer from Kalpesh as well.
My quick answer is definitely yes. And there's quite a lot of evidence to show that debulking with gut-selective antibiotics reduces the leak rate significantly. And to all those things that you have mentioned, I think the easiest thing to reduce your anastomotic leak rate is to do a flexible sigmoidoscopy, or at the very least a rigid sigmoidoscopy, to inspect the anastomosis. Meta-analyses have shown that it halves the rate of anastomotic leak.
Great. Kalpesh, do you use routinely preoperative
Yes, absolutely. Yes, we do. And including bowel preparation, mechanical bowel preparation. And so most of our cases are done laparoscopically. So anyway, we need a mechanical bowel preparation. But routinely, we add preoperative antibiotics. Yes.
Yeah. Sekar, what do you think?
Well, this is a sort of conversation we are having at the moment about pre-op antibiotics. We are going back to the early 20th century, isn't it? Because I remember working with a surgeon who used to give neomycin regularly, and it was stopped. The concern with giving antibiotics is about the C. diff. And it is now well under control here. And yes, there is evidence of changing the gut microbiome, and everything now is labeled to gut microbiome, even cancer, anastomotic leak, wound infection, everything is now labeled to start from the gut microbiome. And you are what you eat is what nowadays everyone practices, but we are very cautious about using oral antibiotics, because the concern is in most hospitals, it'll be difficult to get through the infection control team, because they will see this as sort of practice, which can cause issues with Clostridium difficile. So we don't use it. We use oral mechanical bowel prep before anterosection when we are planning for a loop ileostomy. Just to touch upon loop ileostomy, it is not going to reduce the leak rate. It is reduce the consequences of a leak. The hole is there, but because there is no feces going through, you're not going to get the consequences, which is peritonitis. And certainly, someone who's had a long course chemoradiation, we would be very hesitant to not defunction, because it is a disaster waiting to happen. And especially in this patient who has had a previous resection, recurrence, and we have not touched upon the topic of the effect of anastomotic leak on tumor recurrences. In this patient, it will be certainly something which we would be mindful of. Thanks.
Thank you very much. I think we are running out of the time. One question. There's a question from the audience. What is the role of PET-CT scan in this patient at the beginning, at the initial evaluation?
No role. No role. PET-CT has no role in primary workup of the patient. It is a role only when you are looking for distant metastasis.
Okay. Thank you very much.
Before you wind up, in fact, in this patient, there's something that I would like to know very much, because we don't have a PET-CT, we don't have a nodal. What are the plans about adjuvant chemotherapy now? That's a dilemma that I'm looking at. If I have this patient, I would be really in two minds, whether to give adjuvant chemotherapy or not, because the patient is chemotherapy naive, has not had Folfox or Capiox or anything. So what I would like to know, the treating surgeons, Sri Lankan surgeons, whether they are planning to give adjuvant chemotherapy in this patient.
Yeah, this patient has had uneventful recovery. Now he's waiting ileostomy reversal. The oncologist has decided not to give adjuvant, but they are going to observe.
One thing we would do is we would give some neoadjuvant chemotherapy in the resting period. And there's been some really good work coming out of Brazil from Rodrigo Perez, who has looked at this in some detail. So I think there is mounting evidence. I think we probably need a little bit more study, but I think the place to give the chemotherapy, if they're responding, is in that resting period, in that 12 weeks before you operate.
I think they are balancing the risks and benefits of adjuvant therapy in young patients as well. So, okay, thank you very much. Thank you very much, Ms. Selvasekar, Professor Tan Arulamparam and Kalpesh Jani from India. And let me thank our two colleagues, Rasita Manatunga and Rukman Sanjeeva. Without further delay, we will move on to the next case, which is going to be moderated by Dr. Ramindra Senaratna. Ramindra.
Thank you.
Good evening. Can I invite Professor Rohan Sirivardhana to come and take? come to the stage, please. Can I know if Mr. Altaf Awan is available? Mr. Awan? So I would warmly welcome Professor Rohan Siriwardana, Dr. Udaya Samarjeeva from Sri Lanka, Mr. Altaf Awan from the United Kingdom, and Dr. P. Senthilnathan from India. So we are going to discuss about a 28-year-old female who presented to a surgical clinic with symptomatic cholelithiasis. She had presented with right hypochondrial pain, which is radiating around the body to the back, which was worst after a fatty meal. There is no history of jaundice, and the examination had been unremarkable. And all the blood investigations had been normal. The ultrasound had shown the presence of gallstones in the gallbladder, and she was given a date for a lab chole, and she got admitted for the same 1 month later. At the time of the admission, the doctors noticed that the alkaline phosphatase level was persistently elevated. Therefore, the patient underwent an MRCP, which showed multiple distal CBD stones. So the patient underwent an ERCP. There was complete clearance in the occlusion cholangiogram. Can I ask from Mr. Awan, what is the evidence for performing ERCP and lab chole at the same go, and do you routinely practice that?
Fine. Can you hear me okay, is it?
Yes, we can hear you.
Brilliant, brilliant. Yeah, listen, thanks very much for the invite. Really pleased to be part of this webinar, Bile duct is very close to my heart, because I'm a little bit biased because I do lap cholecystectomy with synchronous bile duct exploration, as a laparoscopic surgeon. But anyway, I've got a colleague in the department who's a surgeon who does both ERCP and laparoscopic bile duct. So I think there is certainly no doubt, there's plenty of evidence, in support of lap chole and on-table ERCP. I think if you look at the randomized trial, which is published in British Journal of Surgery, I think it was back in 2016, which looked at mainly the duct clearance and retained stone rate, after on-table ERCP with lap chole, and they showed very favorable results, where they showed up to 85% duct clearance with less than 15% risk of retained stone in the long term. Now, my personal reservation for such an approach will be many folds, logistically, even in the UK healthcare, it's very difficult to get ERCP in theaters. It can be done in a very rare circumstances where it's real emergency, but usually having the logistics of ERCP in theaters with C-arm, it's quite difficult. That's one limitation in the UK health sector. Secondly, I think there is a very sort of limited training in laparoscopic bile duct for a variety of reasons as well. If you look at the US sort of a literature, a resident in the US, when he or she finishes the training, they would have done only one bile duct in their entire training time period. So you can imagine, there'll be more ERCPists around gastroenterologists and surgeons doing it. My main concern for on-table ERCP and lap chole at the same time as a surgeon would be that if you develop a complication, you wouldn't know which procedure is the culprit. Mind you, therapeutic ERCP has got 5%, and some studies have shown up to 10% risk of complication like pancreatitis or sphincterotomy bleed. And certainly we know for the lap chole that majority can be done safely, but there's always a concern that in case you have some bile leak, from duct of Luschka or a port side bleed post-operatively, then it becomes a clinical dilemma for the patient, which procedures is at fault. So basically, in summary, certainly there's plenty of evidence for on-table ERCP and lap chole at the same time, but there are concerns with regards to, procedure-related complications where you wouldn't know which procedure is at fault, can make the whole thing complicated. And the risk of ERCP-related pancreatitis should not be underestimated. The study, which is a good one from Australia, has mentioned up to 8 or 10% risk of pancreatitis, where half the patients were in moderate to severe category. So that'll be my comment on that.
Dr. Senthilnathan, do you have any different view, or would you prefer to go ahead with a lap chole with a laparoscopic bile duct exploration?
Sorry, Professor Altaf has already alluded to major points with regards to the concomitant ERC with lap chole. I'll start with logistics. Yes, logistics world over is an issue between medical gastroenterologist and the surgeon. I do agree. But at our center, we work closely. We have hybrid OT. So yes, there are, if the situation warrants, our first choice is to do a ERCP with lap chole at the same time. That would be our first choice for the obvious advantage of having it in a single sitting. But having said, there are certain caveats, certain things we need to address before having a successful ERC and lap chole. One is the ERCP duration. Even imagine you have both ERCP facility as well as cholecystectomy by laparoscopy in the same hybrid OT, but certain other factors also influence your outcomes. One is the duration of the ERCP. So obviously ERCP is first followed by lap chole. There are few centers which they do lap chole first and ERCP, which I feel should not be done. So ERCP should be first. With that ERCP comes certain surgeon. One, the longevity of the procedures, more than 1 hour, 1.5 hours, the gaseous distension of the bowel will be there. So it will be difficult. If the ERCP is difficult, then the subsequent lap chole will also be difficult. So we need to do it at some other date, probably 24 hours, not always possible. The second thing is status of the gallbladder per se. Post ERC in the same sitting, we would like to have a simple, reasonably uninfected gallbladder. If it's acute cholecystitis with the ERCP, there will be difficulty in Carlot's triangle, which will be compounded by the gas in the duodenum and in the proximal part of the intestine. So that can be adding more difficulty to the procedures. So these two things weigh in my mind before I select patients for a single sitting ERC and lap cholecystectomy. Otherwise, yes, world over, it is getting popularity, gaining more acceptance for obvious reasons. Coming to Professor Altaf's, post-operative issues, which one is the real culprit? Yes, it's an issue. But with the biochemical parameters, imaging modalities, we can most of the times will be able to figure out what is the problem, whether it is the lap chole or the ERC-induced pancreatitis. So these are my 4 cents of thought as far as the same sitting ERC and lap chole.
Thank you. So the patient develops post-ERCP pancreatitis, which was a mild episode, and she responded well to conservative management, and she made a complete recovery, and she was discharged with a date for a lap chole in 1 month's time. My next question is to Dr. Udaya Samarajiva. Should she have undergone lab call in the same admission?
Yeah, thank you, Ramindra. Now, in this scenario, according to the history, you can clearly see that it's ERCP-induced pancreatitis. And the previous two speakers clearly said that there's a chance of getting ERCP-induced pancreatitis in about 5 to 10% cases. Now, the question here is whether the pancreatitis is severe, mild, moderate, or severe. Because, I mean, we all know that even in biliary pancreatitis, it's currently recommended that if your patient is having a mild episode, to do the cholecystectomy in the same setting. So, I mean, if the ERCP-induced pancreatitis, even if it is a mild episode where the patient recovers within 2 to 3 days without going into any complications, I would think doing a lab chole in the same setting is actually a good decision.
Professor Sirivardhana, what prevents us from doing the lab call in the same admission?
Well, in our setup in Sri Lanka, we work in two different setups. We work in the private sector as well as we work in the state sector. In private sector, actually, we had the facilities at our disposal. So what I've seen is that our surgeons have two approaches. If we get a patient in the private sector, most of the time we will proceed with the ERCP, and at the same time, on the same admission, not at the same instance, but with the same admission, we will proceed with the lab code. But in our state sector, because of our facilities and the theatre times are limited, most of the time what we do is, in the state sector, we do the ERCP and we take the prior decision that we are not going to operate at this admission, and we put get the patient, get a plastic stent. And then we give a date and discharge the patient for a future date for lab call. So it's basically availability of the resources in our two different setups. About this patient, I completely agree with Uday. We take the decision to perform. Now we have performed ERCP and patient got a pancreatitis. Whether we are going ahead with a lab call at this admission or next time will depend on the severity of pancreatitis. But most of these patients, mild pancreatitis, moderate pancreatitis, when the acute attack settles, we will proceed with the lab call.
Thank you. So the patient goes home and she gets admitted 3 weeks later with acute cholecystitis with sepsis, and she gets admitted on the 4th day of the onset of symptoms. There is a rise in the inflammatory markers, and there is a palpable mass in the right hypochondrium on examination, and there is mild elevation of AST and ALT in the liver function tests. The ultrasound that was performed shows that there is a possible intramural abscess of the gallbladder with a possible phlegmon formation, and the arrow depicts the area of the possible intramural abscess. So the patient is managed conservatively. She responds well to non-surgical management, and a repeat ultrasound is being performed about 6 days after the admission, which shows resolving cholecystitis, and she is discharged 1 week later. My question goes to Dr. Senthilnathan. Would you have considered a hot cholecystectomy in this admission?
Yes, the second admission, definitely having suspected perforation with a lot of sepsis, I would have considered a hot cholecystectomy on the same admission. Having said, yes, the logistics wise, you postpone the surgery in the first go itself. If it's a mild acute pancreatitis or ERCP-induced pancreatitis, we can wait 24 to 48 hours and then do the lab cholecystectomy in the same admission where we've done the ERCP. But having said that's apart, at least in this particular setting, in acute cholecystitis with raised counts, reasonably safe period, slightly 5-6 days, slightly difficult, but still You would have all seen a seminal paper published a couple of years back in the Annals of Surgery during the COVID time, that even after the safe period, still we can do. That's from the reputed center published in Annals of Surgery, stressing the importance of early surgery. So definitely I would have considered cholecystectomy during the second admission with all the features of acute cholecystitis. That's my thought at this point in time.
Uday, do you have any other views or would you go the same?
Can I just come in? Is it just to, can you hear me okay? Is it? I just need to.
Pardon me, my question is to Dr. Samarajiva.
Okay, sorry.
Yeah, okay, yes, Ramin. Now, the question that we have to think about is whether the, actually in our setup is actually whether the feasibility of doing a hot cholecystectomy because of the problem of the logistics. But I would agree that with the patient scenario, with the rising counts and also timing of the admission, there is a place for hot cholecystectomy in this patient.
So the patient recovers well and the patient is discharged with a date for lab chole given in 8 weeks' time. And she is reviewed in the surgical clinic in 2 weeks' time, and she does not have any significant complaints. But 3 weeks later, the patient gets admitted to a local hospital with features of acute cholangitis. And the ultrasound scan, which was performed there, shows acute cholecystitis with CBD and CHD dilatation with CBD stones. And the patient is transferred to the regional hospital on day 2 of presentation. And ERCP and stone extraction is performed on day 4. My question is to Professor Rohan Sirivardhana. Would you stent this patient?
Well, this is a difficult patient. Now, already patient had a severe attack of cholecystitis, which there was almost the abscess and had a severe infection. And now coming with the second time with a cholecystitis attack with possible cholangitis and CBD obstruction. So I don't do ERC, but I would like my gastroenterologist, if he performs a ERCP and clear the CBD, to get a stent in, because I'm still not sure whether I'm going to operate on this patient on this admission. So I would need some cover. So I would like to have a stent in, and also this patient, rather than just deciding on based on ultrasound scan, I would also like to get a CT scan done. And with the CT, I can get an idea about the inflammation that the patient has around the gallbladder. It's very badly inflamed, how the Hartmann's pouch and the Callo's triangle is like. Even in the first instance, when the patient had an abscess, I would like to get a CT scan done to make decisions, because if I feel that there is a lot of inflammation, probably in the first instance as well, I will probably aspirate the gallbladder and give some time for the inflammation settle. That's what I've gathered over the time.
Mr. Altaf Awan, your thoughts?
Yeah, I'll come into it here. So just I missed the last session where we talked about a little bit about the hot gallbladder, hot cholecystectomy. So we've published the cases about 500 patients, I think we've got to be very careful when we talk about hot cholecystectomy in a patient like this, where the ultrasound is concerning, the findings are quite severe inflammation. Then I agree with the previous speaker talking about CT scan. I think imaging, ultrasound may not give you the correct information about the Hartmann's and critical view. That area inflammation is the most important area to check before considering hot gallbladder. Now, I've got experience, obviously, like yourself as well, on acute gallbladders or lap choles. I think beyond 48 to 72 hours, it's exceptionally difficult to take out a gallbladder like that. The only ones I've done it safely are within 48 hours. When they come, I'm on call and I can get them to theater within 24, 48 hours. But I almost always get a cross-sectional imaging in addition to ultrasound, because I have been surprised going in, I can't do anything. It was so badly stuck, if simply based on ultrasound. So obviously the patient got better. If not, then cholecystostomy obviously remains a good option. Now coming back to this situation of CBD stenting, my experience in dealing with biliary disease when the stent is placed is that over years, because I tend to do a lot of bile duct exploration, whenever stent is in the bile duct, it makes the surgery even more challenging. Say for example, you have cleared the bile duct, then there's no point leaving a stent in there, because it will cause low-grade inflammation around the bile duct, which will affect your callus triangle as well. Now, this is based on the last 13, 14 experience of dealing with stones where we place a stent, where they can't take the stones out. So I can do a cholecystectomy, take the stent out, take the stones out. But almost always, gallbladder is exceptionally difficult to deal with. So my personal suggestion would be, once you have cleared the duct at ERCP, I think it's unnecessary to leave a stent, which will lead to low-grade inflammation in the bile duct, and then subsequent gallbladder will be even more difficult. Secondly, whenever I have patients, say for example, with CBD stones which can't be cleared, then I tend to give them a date, a planned date. I don't put them on the waiting list for 4 or 5 months. Then you have to have a very careful planning. Obviously, it's a completely different topic, but certainly I wouldn't leave a stent in the bile duct if you're planning to do something in the near future. And I'm concerned about pancreatitis, cholecystitis, and cholangitis now. I think it's getting more challenging, I think, clinical condition as far as I can see.
Mr. Senthilnathan, what would be your plan of management from this point onwards?
So I have a different perspective. In our institute and the majority of the centers across India, we try to stent it. It's a short time stenting. So even in the prior first ERCP itself, we would have put the stent. Probably if we would have put the stent in the prior ERCP, now the chance of cholangitis would have been reduced. I'm not saying we can totally avoid cholangitis, but probably bile would have died by the side of the stent. So the chance of cholangitis would have reduced had we put a stent in first go. Having said, definitely in the second sitting now, I will consider putting a stent along with the CBD clearance. It gives two benefits. One, while we are doing a cholecystectomy, we will have an assurance that when we hit the bile duct, it cannot prevent, definitely I'll tell you, it cannot prevent bile duct injuries, but it will help us to identify that we have hit the bile duct. Point number one. Second, if there is a recurrent stones slipping out from the cystic duct onto the bile duct, it's now the second attack of cholangitis before the lap cholecystectomy can be prevented. So our way is a policy is to, and there are again literature wise, just a sphincterectomy without stenting, CBD removal is also totally acceptable. With or without sphincterectomy, with or without stenting is totally acceptable. But our policy is do a little bit sphincterectomy and remove the stent, the stone, as well as put a stent, which will remove anyway between 4 to 6 weeks after the gallbladder is out. So that's our policy. And with regards to Professor Altaf's observation that stents try to have a pericholecdocal inflammation, yes, I do agree. There will be some inflammation, but the moment we meddle with the CBD with or without stent, there's definitely going to be some inflammation. So post, ERC stent, our incidence of CBD explorations have come down, but nevertheless, in some tough situations, we need to go and then identify. Again, that's in a marker, whether intraoperative ultrasound or any other modalities that gives, a roadmap that stent is there inside the bile duct. So our policy stent
Right. So the patient undergoes a laparoscopic cholecystectomy on day 7 of this admission. Uday, can you please tell me whether this was a good decision?
Yes, Ramindra. Now, going through the history and also with these repeated complications with pancreatitis and getting a second episode of acute cholecystitis with CBD with cholangitis, I would agree with the previous two speakers, but just coming back to the previous, just highlighting, I think I would leave a stent initially, and I wouldn't do surgery at day 7 because now with this repeated infection, this would be a very difficult cholecystectomy, and identifying the callous triangle anatomy will be extremely difficult with the recent cholangitis as well as the two recurrent cholecystitis. So I think I would wait a little with a stent, probably for 6 to 8 weeks, wait with antibiotics and wait the infection to settle. And possibly with reimaging, I would go for cholecystectomy. So I don't think this is a good decision to operate on this patient this early.
Professor Sirivardhana, do you have any other thoughts?
No, I also agree with Uday because it's a quite bad, really bad time to operate this gallbladder with this history. And on the 7th day, unless the patient is having any life-threatening, complication as a result of maybe perforation, which you can't manage with interventional radiology, possibly, not possibly, actually, I will not think of operating this gallbladder at this point.
Mr. Awan, any thoughts?
Totally agree. Totally agree. So vast majority of the surgeons in the UK would agree with that. They won't operate on a patient like that. And I certainly agree. Alternative situations like cholecystostomy, if it's only absolutely necessary, yes, patient septic, not better. That'll be another thing to have in mind. In case, now this is exceptionally rare. I don't think in UK surgeons will operate, but in case someone goes in, I think second surgeon opinion and exit strategies should be in your back of mind. Otherwise, first of all, shouldn't be going in these situations.
So all of us agree that this shouldn't have been done. And the patient's recovery is prolonged with jaundice and recurrent sepsis. A repeat ERCP is performed on day 18, and it shows a complete cutoff in the common bile duct. Patient has recurrent bouts of cholangitis, and the patient is transferred for further management. Professor Sirivardhana, what went wrong?
I think the decision to operate, probably as we discussed earlier, I think should probably not would have delayed the surgery. And if, as Mr. Altaf said, if we by chance if you decide to operate, let's say in emergency, then possibly I may not try to do a total cholecystectomy. Possibly I'll think of doing a subtotal and go right as much as possible down, remove the stones in the gallbladder and close the gallbladder, removing as much as possible, not going close to the common bile duct, especially in a patient like this. Quite difficult to go right up to the cystic duct, Hartmann spout junction. Possibly was trying to do too much at that instance. Sometimes you get carried away and you try to, you feel like removing the whole gallbladder, but the aim should be to get, in a patient like this, aim should be to get the infection under control and save the patient's life.
Dr. Senthilnathan?
Yeah. To the previous speaker that we should be having a modification for doing in such a hostile environment.
And Dr. Senthilnathan, can't hear you properly. Can I ask Mr. Awan to respond
Yes.
until?
Yeah, sure. Yeah, I think I totally agree, what has been said before. In these situations, if someone goes in, I think in our series of about just over 500 patients, give you the personal experience, about subtotal rate is about 3 to 4%, which is reasonable. And it's better to accept in future stump cholecystitis rather than anything going wrong with the bile duct. And I've done about 4 completion cholecystectomies, roughly around 2 to 3 years after the initial subtotal. And believe me, when I went back in, it was straightforward, just removal of the stump. So I think exit strategy with bailout, safest option. Don't worry about leaving 3, 4, 5 centimeters of gallbladder. I agree that stones, make sure, just put a scope in, just wash out the Hartmann stone is out and leave the stump and live to fight the battle another day, which usually will be fine after if the patient develops stump cholecystitis in future.
Dr. Sendilnathan, are you with us? May I direct this question to Dr. Udaya Samarajiva?
Yes. Yeah. Now, actually, the decision to operate was actually it's wrong decision, but in this case, what I would have done is keeping in mind that the chances of doing an open call is also high. And I would also agree with Professor Rohan Sirivardhana that the main idea here is to actually control the sepsis and to take out the stone. So rather than going to dissect in the triangle, which is not very clear and which is dense with the inflammation, I would go for a subtotal cholecystectomy and take out the stones and come back safely so that the patient wouldn't end up with a bile duct stricture like this.
All right, thank you. So the patient was discussed in a hepatobiliary MDT. An external biliary drain was inserted because the sepsis could not be controlled, and the patient is awaiting definitive surgery. Professor Rohan Sirivardhana, now, given that this patient is in this state, what would be your plan of management? And how long would you wait?
Well, this patient now the ERCP shows that there is a cutoff at the low end, but I would like to have an idea about the upper end as well. And for definitely I'll do a MRCP just to see how the intrahepatic ducts and the common hepatic ducts and what kind of stump that I have to work with. And also I'll definitely do a CT angiogram, a CT abdomen and an angio to have a look at the hepatic arterial anatomy, whether the right hepatic artery is intact or not. Because in an injury like this,
is it likely to be intact?
I'm sorry?
Is it likely to be intact in an injury like this? With the history?
Yeah, this is a kind of injury where a portion of especially common hepatic duct is taken off, and the right hepatic artery goes under the common hepatic duct, and there is associated right hepatic artery injury, and I would like to have an idea about it because that might affect the outcome of the repair. So that's what I would start with, and then with that information I'll decide the timing of the repair and exactly what kind of repair that I'm going to do.
Mr. Awan, any thoughts?
Yeah, I would agree with this. Personally, in our center, we're fortunate. I think overall we are very fortunate overall worldwide. BD injuries are not that large. 1 in 300 is the risk that we quote, but we refer them to a tertiary center. We don't do bile. I do a lot of bile duct exploration, but if it comes to biliary injury requiring hepatic judge, we refer it to one of our tertiary centers. But certainly, totally agree. Vascular anatomy mandatory to check because unfortunately the risk of biliary stricture at the anastomosis and subsequent secondary biliary cirrhosis, is something which is not a nice thing from patient point of view in the long term.
Udaya, may I ask you, if we go through this patient of what happened to her, where could we have changed things?
Going to the history, I mean, there are two critical points where we could have changed the scenario. First thing is when she was detected to have gallstones prior to the lab coli in the common bile duct, and what I would have done is I would do as a general surgeon, I would be very comfortable to have a clear duct before going for the lab coli. So my options are to send to a colleague who is doing ERCP, get the bile duct cleared, and then followed by laparoscopic cholecystectomy afterwards. Or if I have the facilities, what I've done is I would do it in the same setting. So that was a critical point where I think we have missed, and the patient has to ultimately suffer with this disastrous event. So that is one point. And the other thing is a second situation where the patient presented with cholangitis. She had a ERCP and a duct clearance, and she was subjected to early surgery when there was ongoing biliary inflammation, and where the anatomy was obviously very difficult to identify. So I would have avoided that situation and wait for a reasonable period like 6 to 8 weeks for the biliary inflammation and the inflammation to settle back, and then would have reimaged and then decided to do surgery afterwards. So I think these are two critical points where the decision making was actually wrong, and that had led to a disaster.
Dr. Senthilnathan, are you with us? Okay,
So-
there are some questions. There are some questions from the audience.
Yeah.
The first question is the time frame between the ERCP and a subsequent lab coli. Mr. Awan?
Yeah, so I think again, what my comment will be, I'll be slightly biased because my plan in these cases is, if they're fit in well otherwise, I do a single stage lap coli and bile duct exploration. So
Awan, in our setting,
can you hear?
just to interrupt you, in our setting, we don't have the
Yes.
facilities
Coming to it, yeah, coming to it. So what we are trying to do is, it's not only your centers in Sri Lanka, but in UK as well. You can count people on your fingers, how many people can do a single stage. So certainly it's an area which I'm trying to promote as a director of education in ALS as well. It is something which benefits the patient, and the hospital as well, that you can have done all in one go. But unfortunately, you're absolutely right. This is something which is not available everywhere, so I think time period from ERCP to gallbladder, it's the important thing to remember is gallbladder is a dynamic organ. It's not sitting silently. So risk of recurrent infections, risk of further stone migration will always be there. You cannot give guarantee to any patient. Main thing would be decision making, which may involve more than one surgeons, to be honest, to prevent any of those disasters. That's what I would what my take would be on this.
Okay, thank you. The second question is place for ultrasound guided gallbladder abscess drainage in the second admission. Professor Sirivardhan, if the patient was responding to conservative management, would you still go ahead with ultrasound guided drainage?
Well, in the ultrasound, there was it said that there was abscess, and definitely, I as we discussed earlier, we'll do a CT. I need to have a look at the cross-sectional image and do a CT scan. And if the patient is having abscess and if there's significant inflammation, I've tried two options. One, if the patient is not that bad, I'll ask the radiologist to pass a needle and aspirate and see how the pus, if there is very thick pus. And if he feels like he can't get everything out, I'll ask him to pass a drain. If not, I'll ask him to aspirate and see whether the patient responds with antibiotics. And if the patient responds with antibiotics after aspiration, then I'll proceed with antibiotics and then go ahead with the interval cholecystectomy. But if not, possibly we'll put a pigtail drain.
Thank you. Dr. Sindhilandan, welcome back.
Yeah, thank you.
In your absence, we discussed about the current status of the patient, where the patient has got an EBD because the sepsis could not be controlled, and the patient is awaiting definitive surgery. Your thoughts on that? What would you do?
Yeah, thank you. Yes, during the surgery itself, as I told you, it has to be careful. So right from we have three admissions. In the first admission, see, I'm not very particular about single sitting in the same sitting, but in the same admission, generally we prefer. If it's not in the single sitting, same admission. If it's a mild pancreatitis, we'll wait for 24 to 48 hours and then do the lap cholecystectomy in the same sitting. That is our policy. And the majority of the centers in India, they also follow the same thing. We don't wait for a month or 6 weeks after the stenting. Second point is, we would have done it in the acute cholecystitis, we wouldn't have conserved majority of the time. For some other reasons, we can do it, but majority of the time. That's a clinical pathway which we follow. The third thing, yes, I totally agree with the rest of the panelists. Third time, infection is going to be a hell lot of problem. Yes, the safe bet would be to put a cholecystostomy, tide over the crisis, come other day, maybe 6 weeks later. But having said, as I told you, with the available expertise as well as the infrastructure, we still can go. In that, I'll be very careful. I should be having, as Alta pointed out, we should be having all the team ready, lab ultrasound, good team, as well as probably an ICG guidance. All these things will help us to identify the bile duct, prevent injury, duodenum. If it gets stuck, we need to carefully dissect it out and then do the procedure. That's also a point. But if there is a complete cutoff, coming to the fourth scenario, the last scenario which we have discussed today, what happened when there is a complete cutoff, when we had the lap cholecystectomy, this is extrahepatic injury. On these these injuries are very high up, associated with vascular injuries. So it's really vasculobiliary injuries, very difficult to treat. So generally, we need to have delayed repairs are better. Of course, the evidence is for and against early versus late, but generally we are a proponent of a delayed repair. EBD insertion, yes, that's a good way to tide over the crisis. If it is a complete cutoff, the bile is totally diverted in the sense with the HIDA scan. We always do a HIDA scan. If there is a complete cutoff, if there is a little bit of biliary entry continuity, then probably we can wait. Otherwise, complete cutoff, no biliary entry continuity, we need to have encounter a lot of problems, including electrolyte dyselectrolytemia. Probably we can consider bile refeeding with an nasojejunal tube till the inflammation settles. In about 6 to 8 weeks, probably little more than that, 12 weeks I prefer. More than 12 weeks, that means 3 months after the injury, good dilatation, we can go for a definitive surgery. Before that, if we try to attempt, then the results will be suboptimal. Results also have shown that one.
Thank you. Professor Sirivardhana, would you put the same emphasis on a HIDA scan?
Well, actually, my experience is very limited with HIDA scan. We do not have it at disposal. So most of the time, what we do is we decide, we make our decisions based on the MRCP scan.
And the last question for the session is place of intraoperative cholangiogram in hot cholecystectomy. Mr. Awan?
Thanks. Obviously, we are selective and routine ones, I'm sure, all over the world, I think in this particular case, if you are asking me, what is my experience in hot gallbladders, cholangiogram, tough. Depends, what you call hot gallbladder as well. I'm looking at, that Tokyo classification. I think some of these cases, or I say majority of the time, once you just about get to the callus, you have enough duct to put a clip on. So not easy. They're quite challenging. Hot gallbladder OTCs are not straightforward. Now we do a lot of, these biliary colic stroke, bit of a cholecystitis. You can do, on-table cholangiogram. Sensible thing to do. If you have a facility and you have the staff available, you can do the interpretation. Obviously, again, it's variable from center to center. But our approach in vast majority of the centers in the UK would be selective. Hot gallbladders, depending upon the severity, always think is going to be challenging. ICG role in hot gallbladders, because I'm very strong proponent of ICG for a variety of other conditions as well. In gallbladder, unfortunately, has been disappointing, especially if there's acute inflammation. The reason is that you have got a lot of edema, and the fat is edematous as well. Your scope won't pick up the signal from the bile duct. So just be aware of that. Standard gallbladders, elective ones, biliary colics, mild inflammation, ICG will come into the bile duct, you'll be able to see it. But acute inflammation, just beware. It might take a number of hours to get to the bile duct. If there's stones in there, you may not see it. So yes, cholangiogram, intraoperative ultrasound, and yes, ICG, they're all complementary here.
All right, thank you very much. That brings us to the end of this session. And I would like to thank Professor Rohan Siriwardana, Dr. Udaya Samarajiva, who are my good colleagues, and Mr. Altaf Awam and Dr. Senthil Nathan for your presence and your thought-provoking talks. Thank you very much.
Thank you so much.
Thank you.
Thank you. Enjoyed all the discussions from all the panelists. Thank you very much.
And now I would like to invite my colleague, Dr. Kapetiagama, to move on to the third session.
Good evening. Even though it's last, it's not the least. I think it's all of you seems to be a bit hungry. The upper GI tract always ready to absorb whatever we want. I think we have a strong lineup of speakers who are reputed speakers all over the world. And may I welcome Professor YKS Vishwanath from UK and Alsgbi representative, and Mr. Sritharan Kadir Kamanathan from UK is expert in upper GI, plus actually is my trainer in the UK. So, and Dr. Roy Patanakar from India, and Dr. Sanjeev Samaranayaka, Sri Lanka, and Dr. Manjula Patirana from our Sri Lankan, our own friends of Slamads. So we have an interesting case today to discuss. It is, right. So it's a 55-year-old male having reflux symptoms for 6 months duration. And on and off, the patient was given some PPI and was tried on lifestyle modifications, and his symptoms not improved. So surgeon who saw the patient decided to do an upper GI endoscopy. And this is the picture of upper GI endoscopy. It's a 3 centimeter sliding hiatus hernia. So with enteral gastritis. If I, Sanjeev, so this wording, if you look at wording of reports, there's a huge variation. Some people say mild, some people say moderate, some people say severe. This is very bizarre, isn't it? So to talk to someone scientific, to talk to a colleague in more relevant, how do you document proper way of upper GI report?
Yeah, you're very correct, Chaturanga, because because the management wise, depending on the classification, it's very important to classify this hernia properly so that everybody can understand it's somebody else. So you have these markers on the endoscopy, so you have to always correctly state the length of the length of the hiatus hernia. It's very important by using the markers and also by using the standard Hill's classification. It's very important to classify it properly.
Yeah. So it's a very important for you, all the trainees. Please document properly and to convey the message properly when it comes to hiatus hernia classification, because this mild, moderate, severe hiatus hernia is not a good way of documentation and discussing with someone. Your mild may be different and maybe someone else, it may be bigger hiatus hernia. So then what would you think the next step should be? Because it looks a big hiatus hernia, is not responding to treatment. So what investigation, Manjula? What is the importance of manometry actually from Professor Vishwanath? So if you can tell the importance of doing manometry in this patient, will it help? Professor Vishwanath, the question from you is what is the importance of pH manometry in this patient? He's an unresponder and he's significant 3 centimeter sliding hiatus hernia. So what is the importance of doing pH and manometry in this patient? I think Prof. Vishwanath, you are muted. Is it possible to switch it on?
He probably can't hear you.
Prof. Vishwanath, yeah, you're muted now. Okay, so what is the place of importance of pH and manometry in this patient, Prof. Vishwanath?
Hi, sorry. What's the question, please?
Question is, this patient is having a 3 centimeter sliding hiatus hernia.
Yeah.
He was not responding to medical treatment and failed medical management and the lifestyle modifications. So therefore, we thought of pH and manometry. What would you think, the place of pH and manometry in this patient?
Yeah, that's a good question. So basically, this chap, I presume he had a visible gross esophagitis, and he has had some barium examination. So at least in UK, before any anti-reflux surgery, as per BSG guidelines, we tend to quantify objectively both manometry to rule out especially motility issues such as achalasia or gastroesophageal obstructive syndromes, junction syndromes, and pH studies to prognosticate further. But the evidence of favoring this is moderate. If you look at the published evidence last 22 decades, but at least in UK, we recommend, the strength of recommendation is strong towards carrying out esophageal pH and manometry. So, but my practice is depending on the patient selectivity and of course structural problems such as this. We have got a demonstrable hernia, and I sort of a bit more selective. But at least the UK generally we do both pH and manometry before we embark on any invasive surgery.
Okay, thank you. Manjula, what is the place, because we are a resource poor country, sometimes, we face big difficulty finding only few places having pH and manometry facilities. So what is the place of doing pH and manometry, in a resource poor setting? Can we proceed without any?
I think that's a good question, but as this is a non-urgent or non-emergency operation, we have to get manometry, at least manometry, because motility disorders like achalasia may present in the same way. The pathology may be same,
if you do the fundal rep, that is going to be a wrong operation. And secondly, we have to have a kind of a roadmap. Certain hypokinetic segments in the esophagus, then the esophageal clearance, even with physiological reflux, then may simulate the condition similar to reflux, pathological reflux. So then it is not a kind of a contraindication, but then you have to modify your rep according to the manometry report.
Oh, thank you, Manjula. So when we are sending for a patient for pH and manometry, we have to contact our gastroenterology colleagues. So how to prepare a patient for pH and manometry? Sanjeev, could you explain how to prepare?
Yeah, so most of the time these patients are on the GORD medication, which need to be stopped. So at the time of referral, you had to break the bad news and explain to them that these had to be stopped, but it will be done once you are referred, and the gastroenterologist who's performing the test would advise them. So PPIs to be stopped for at least 1 week. And then H2 receptor blockers for 4 days at least. Then we then keep the antacids going, and then that they can stop just 24 hours before the procedure. Then because the manometry wise, esophageal motility, the drugs that can affect the motility like prokinetics, then calcium channel blockers, opioids, things like that need to be stopped 24 hours before the procedure. And also we had to advise them to be off nicotine, and then also things like caffeinated drinks prior to the procedure. And then, of course, they'll have to be fasting for 4 hours for solids, and then 2 hours for liquids just before the procedure. But if we see any residual food on the endoscopy, like in place of achalasia, then they might have to be kept fasting for longer.
Okay, thank you very much. So, Manjula, what are the important indicators you look at in, when you look for intervention? What are the things you look in the report?
Yeah, Chaturanga. Now it is like this. Now, when you do the endoscopy, reflux-related complications like strictures, which is very rare, I have not seen, and the Barrett esophagus, or complications like pulmonary complications because of regurgitation, are clear indicators for surgery. But one must make sure that the diagnosis should have confirmed by manometry and the pH monitoring before proceeding with surgery. But out of the report, most important indicators, just presence of acid without symptoms to the patient should not be a reason or should not be a trigger for the operation. So I think in the pH report, symptom index, that is what patient feel out of the number of reflux. That is, if it is more than 50%, then that is kind of an indication. With the presence of Demister score more than the pathological level, generally considered 14. And then the symptom associated prediction, that is more than 95% prediction is kind of a SAP, is kind of a indicator. And the SSI, symptom severity index, which is more than 10%, is considered pathological, and then kind of useful indicators to proceed with operative management.
Yeah, thank you, Manjula. The important points are, when I talk to my gastroenterology colleagues, they said the Demister score is not that important. Sri, Mr. Kadikamanathan, could you, elaborate? Do you have any idea about that? Look at this report. In addition to Manjula's view, as you are an expert on this field, do you love physiology of upper GI? So, would you like to comment on that?
I think, Chaturanga, can you hear me at all? Or?
We can hear you. We can hear you.
I think, pH impedance is the important one, because you can have acid reflux and non-acid reflux. So I think it depends on the symptom correlation is one of the important ones. I think the pH of 4 is interesting because Demister all those years ago did the study. I don't know if anybody ever read the study. It was based on patients with and without endoscopic evidence of esophagitis. And based on that, he I had a 4% number, but then you sort of retrospectively then added on to every patient saying that anybody over 4% had reflux. So we don't know for sure. I think the key thing is the technology has improved. The 24-hour pH with impedance, I think, is more important. Reflux events are important, and is there any correlation with the symptoms? Because I mean, there are a lot of patients who press the buttons so many times, yet there's no correlation with reflux. So you've got to be very careful on that.
May I make a comment? May I
Sorry,
comment on this?
Beg your pardon?
May I make a comment on this?
Please.
So normal manometry is not enough for me. A patient who is a PPI non-responder is a red flag as far as anti-reflux surgery is concerned. So
I agree completely. I absolutely agree with you on that.
I wouldn't touch them with a barge pole if they don't respond to PPI. I also want some information on the patient's BMI to see if he's morbidly obese, if he's consistently taking PPIs, if he's a smoker, he's alcoholic, he's on NSAIDs. All these are important points. But this to me is a red flag to do anti-reflux surgery. When I do a manometry, I want information on the body motility, the LES pressures, and the distal contractile index. Only on that basis, I would take up a patient for surgery, not on a DMeister score. I actually would do a pH study only when the diagnosis of reflux is in doubt, like in this patient. But esophageal manometry and impedance in every patient.
Can I also add to that? I entirely agree with you, and also to say that we did look at this. I wrote in many years ago in 2004. We looked at after having done over 200 anti-reflux surgery when I was a youngster, and we showed that people who respond to PPI do well with surgery. People who don't respond to PPI don't do well with surgery either. So I mean, these are the difficulties in anti-reflux surgery.
Thank you very much, both of you. And Prof. Vishwanath, if I ask you, is there importance of doing a CT scan? Is it regularly we do, or do you? Is there any place for any selected cases?
It's a good point, and obviously, if it's a primary anti-reflux hiatal hernia surgery, especially type 1 hiatus, such as the one which we're discussing, I would not do routine cross-sectional imaging. But if it is a paraesophageal hernias, type 3s, sometimes 4s, or revisional surgery, it's important to look at structural complications. And also, it acts as a directive to, if you're planning for a revisional surgery, the cross-sectional imaging, especially sagittal and coronal views, is so important, with a bit of a contrast. But not primary, not for all primary GOP standard anti-reflux surgery, we do not do it.
Thank you so much. As we have evidence for us to do an intervention, such a SAP is 95, DMeister score 125, which is the 14.7 is the cutoff value. When symptom index 60%, normal is more than 50% should be there. So, but having a normal manometry, we decided to do a fund application because surgical intervention. So my surgical trainee, I think not this time, but this was about 2 years ago. So then, because as it's the best modality, he offered Nisane fund application. But finally, we decided to do a 2-pay fund application. Do you? How do we make that decision? Do you agree, Dr. Patankar?
So firstly, I wouldn't operate on this patient. If he's PPI non-responsive, I would not operate on him. I would look for alternate diagnosis to see why he's got symptoms. But just to ask, if you ask me which wrap I do, they're always posterior wraps. I would choose whether I do a partial 2-pays versus a full Nissan's based on the body motility. So any young patient who is volume refluxer and who has normal body motility would get a Nissan. Anybody who is above 50 years of age, has ineffective esophageal motility, has any atypical symptoms, would get 2-pays. We do about 100 fund applications a year in our department, and about 70 of them are 2-pays, and about the rest are Nissans.
Okay, thank you. So, a significant bloat. So, in that scenario, so sometimes significant bloat that was the reason I think we thought of doing a two-pay on that. Mr. Ramanathan, do you want to comment on that?
Sorry, as you know, I usually do more two-pays rather than Nissen-Fund application, but I agree with you that I have to say, I wouldn't have done surgery on this particular patient, but if you're going to do, the question is, what do? You predominantly do two-pays rather than Nissen-Fund application. I have to say, my numbers of fund applications have gone down and down over the years as I get older, I guess.
Yeah, myself, I've not done 2,000 operations yet, but it's more than 1,400 operations. And last 12 years, 90% of my fund applications are two-pay fund applications.
Thank you, Prof. Vishwanath. So I'll ask, so when we decide this, it's a large or medium or this hiatus hernia, so how do we, select a case? This patient is suitable for surgery, and in this patient is suitable for endoscopic interventions, because we know the gastroenterology colleagues are doing a lot of endoscopic intervention all over the world, and there are many available. So what do you think about it, Mr. Kamanathan, if you can explain?
I think that having, my PhD was on endoluminal surgery many years ago with Professor Paul Swain. But the problem is that there are no long-term data in endoscopic surgery. And they, of course, if you're talking about this particular case, they shy away from hiatal hernias anyway. I think the problem is long-term data there aren't many long-term data either for laparoscopic fund application or for endoscopic surgery. If you look at, I went back and had a look at the data on laparoscopic fund application. The best we have is 5-7 years, nothing beyond that. People don't look at these patients beyond that. So that is the difficulty. So if you ask me, which one would I go for this particular case, assuming that, let's forget about all the caveats and all the reservations we mentioned previously, I think surgical intervention, because you will repair the hiatal hernia anyway. In that sense, I would say surgery, but that's with all the caveats. Yeah, but what's interesting is that what is interesting for me is that recently we went for this at the UK, at least went for one of these anti-reflux surgery, symposium, and this was a few years ago. And somebody in the moderator asked, which of you guys in the audience will have anti-reflux surgery? None of them put their hand up anyway. So it'll be interesting.
That is interesting. Because many endoscopic interventions, because nobody really wants a surgery. If there's an endoscopic interventions available, there are many RFA, clipping techniques, suturing techniques, many things are coming into the market. As surgeons, I think we should be completely aware of that. That's why, we put.
So if I intervene for a minute to say, there are three endoluminal surgical interventions. One is endoscopic implantation techniques, which you're talking about gatekeeper system and etc. Then the second is endoscopic escarification. In other words, in some way you're going to induce scars, like for example, the stretta, that sort of interventions. And thirdly, some form of surgical intervention, like endocinch or the newer stapling devices. But the problem remains, in a way, we don't know the long-term results.
Yeah, can I just come in? Thank you for that. We are one of the European largest center for endoscopic strata in not just UK, Europe. So our paper is going to sort of come out 4.5 years data. I think this particular patient is outside the remits of any endoscopic therapy, as Sri said, and I entirely take that point. We have done 240 or 250 strata procedures, largest in Europe last few years, more so in UK, and I train and mentor. But most important is selection criteria, and we have published as well some validated initial scores. But it's important to recognize that there is a role of endoscopic therapies in some patients, but in not all patients, but certainly not in this patient. Thank you.
I think you're comparing apples and oranges, really, because the large hiatus hernias go for surgery, and those with lax GR or small hiatus hernias are considered for stretta or endocinch. We did a trial for eagle claw as well. And I think the only promising data really is on the links, where laparoscopically you implant a ring around the OG junction. So I think this is apples and oranges. There are two different sets of patients which we can't compare.
Thank you. And we decided to, as we decided to do a two-pay fund application, generally, how do you decide a type of wrap, as, this, like DOE fund application, two-pay, and Nisane is available. Dr. Patankar, could you explain that in how do you make, decision to do DOE fund application, or what is your practice, and how do you proceed with that decisions? As you mentioned a little about the volume reflux and proceeding for Nisane. So could you talk on that?
We do the DOR fund application only when we do a cardiomyotomy for achalasia. I am aware only of Professor Watson's work from Australia, where he showed that DOR was as good as posterior fund applications. So in our department, I would say 97–98% of patients have posterior fund applications. The majority, about 70% of that 95, would be two pays. And as I told you, the only patients I do a Nissan's is young patients below 40, those who have normal body motility, those who have low LES pressures, and those who are PPI responsive. Only those patients get a full Nissan's, all others get two pays. We know there is enough data that the two pays is as durable as a Nissan's and has lesser dysphagia and gas float. So I think for me, that's a clincher.
Thank you. And one aim is doing anti-reflux surgery is to take them off PPI. But Dr. Patankar, if you look at this surgery, and they already have, some people have antral gastritis. Can we completely take them off PPI? Do we need to continue in certain patients? What is your view? Because they expect us to cure everything by doing anti-reflux surgery. So this is a balance between the patients and the reality. So what is your view on that, please?
So it's not only the antral gastritis. A lot of these patients will have Los Angeles grade A or B esophagitis. For both these, I would keep them on PPIs for a month. And I tell them this pre-operatively, that you need to stay on a PPI for a month and then discontinue that.
So, Manjula, any views?
I think we have to take a separate entity compared to reflux esophagitis. For general practitioners, it is one field for everything. But for us, I think at least we should try PPI 6 weeks to 8 weeks before deciding for the surgery, because there may be a overlap of.
Thank you, Manjula. It's very important because anyone wants to make a comment in the panel? Actually, what we generally do for anti-reflux surgery, always we in the endoscopy report, so which might not completely cure by doing anti-reflux surgery. Please do come in and tell the patient beforehand, well ahead, because otherwise, we have to deal with the expectations of the patient, and they might not be happy with our decisions. So, Sanjeev, well, I did this wrap, and before discharge, what advices, dietary advices would you give to this patient, on the discharge?
Yes, Chaturanga. So generally, first post-op day, we would start them on a liquid diet, and then on the maybe second day onwards, we'll start the patient on a pureed sort of a semi-solid diet, which we'll keep on for 2 weeks' time. And then after 2 weeks, get them onto a normal diet. And it's very important that they avoid fizzy drinks and then spices and then oily food, because the belching and bloating is going to be difficult for these patients with a wrap. And also PPI and the prokinetics, we continue till 2 weeks' time and then get them off that after 2 weeks.
Okay, so that means you're going to continue PPI for 2 weeks and going to discontinue. So prokinetic, what is the place? Generally, do we need to continue anything from, our overseas experts? Any idea about the discharge planning of these patients?
So we take out the nasogastric tube on table, start feeding them clear liquids in 4 hours, and typically discharge them at 24 hours. Our protocol is 7 days of thick liquids, 7 days of pureed food, 7 days of solids with avoidance of raw salads and carbonated drinks, and avoid alcohol for 3 months. I do not usually give motility agents post-operatively, just PPIs and some simethicone containing antacids. That's to take care of whatever gas flow there may be. Important that the first 24 hours, we keep the patient in a propped up position. Make sure he or she doesn't get vomiting. So use adequate antiemetics. Make sure he comes out of anesthesia smoothly. These are all ways of preventing crural disruption and RAP migration.
When I going to take the NG out, Prof. Vishwanath, so when I generally going to take the NG out straight away after surgery, or is it you wait some time?
No, I don't put any NG tubes. I put borogastric tube during the operation, just sometimes a bit of a gas in the fundus of the stomach, and we take it out before extubation. So I do not use any bougies, and I will ask the patient to stop PPAs on the same night. And usually I tell them just take some Gaviscon as a reminder. From the point of diet, in UK, if I ask them to drink, they will eat. If you ask them to eat, they will have a steak tonight. So I used to get calls from the downside, "Oh, Fish, you did the operation 2 weeks back. I can't get my steak down." So we just go a bit of a grade 1 approach, first gear approach. I call liquids for a couple of weeks, and then the thicker liquids like porridge or whatever. So first 4 to 5 weeks, we just give. I don't give any dietary sheet. I explain and emphasize the importance of consistency. That's it. And again, simethicone containing some oral antacids is certainly helpful first few weeks, because it's an adjustment and mindset towards their operation that requires a lot of counseling before and after. So yeah, I don't put any NG tubes. Sometimes if I do before 11 o'clock, they'll go home on the same day. Otherwise, if it's after midday, then they will stay that night and then go home. In UK, we classify day case if they go home within 24 hours. That means 23 hours discharge, as we call it. Yeah, that's my way of majority of the primary anti-reflux surgery.
Thank you, Prof. Vishwanath. So if I go back a little bit about this surgery, I could not ask you, Mr. Kadikamanathan, how do you strengthen the crust routinely, or is it depending on the size of the crural defect, you decide how many stitches you put? And could you comment on that, because we need to strengthen the crural defect as well?
Yeah, always repair the crural. I take 1 or 2 of the short gastrics during surgery, but other than that, I'm sure it's standard for everybody, the same, But crural repair, we always do.
Okay, thank you. What is your practice, Dr. Patankar?
So crural repair in all patients, but we need to leave enough gap between the last suture and the esophagus for the food bolus to go down. We've published our own technique comparing using an esophageal bougie versus putting in a Fogarty. So we use a Fogarty 6 number and inflate the balloon between the last stitch and the esophagus just to have some. So there are various fellows who operate in my department. So we want to have an objective way so everyone does it exactly the same way. So that's our technique. I think the SAGES also has a grade A recommendation that there should be a crural repair in all patients, period.
Thank you. And when this patient came back again, he was discharged successfully, went back with recurrent symptoms after 4 months. It was partially relieved with cough. So if I look at only these 2 parts, when you on long run, Prof. Vishwanath, can they completely stop lifestyle modification, or do they need to continue the lifestyle?
Sorry. No, yeah, long run. I tell them, to stop it before discharge. As such, of course, the problem is in wherever, including UK, where we have got reasonably good follow-up with our patients or with the GP. And when they go back with any chest discomfort or throat pain or some tummy pain, patients will be started on PPIs. It's beyond our control. And also last few years, over-the-counter PPIs also is available. So usually 90% of in my practice, first few years, what everybody thinks recurrence of symptoms is not due to recurrent true reflux. Whenever I do post surgery for recurrence, pH scores and all those things will be normal. But nonetheless, majority of our patients, without our understanding, go back to PPS after a few years. It's very difficult for us to sort of quantify as such. But if you see them first few weeks or first few months, I'll ask them to stop. Usually they will stop and they would not notice any difference, whether or not.
Thank you. So, as 1 year later, I think patient had recurrent bouts of vomiting, and we didn't repeat upper GI endoscopy. We looked, the RAP has slightly migrated. So then we did a barium swallow. So Dr. Patankar, could you comment on this, and what is the place of imaging? Do you do routine barium swallow, or is it on selective cases? When it suspected RAP migration, what do you do?
The only time I do a barium swallow is when I have a patient who has a stricture which has been dilated several times, or when I suspect a shortened esophagus. I would do a contrast CT in every redo patient, in every large giant hiatus hernia, and every paraesophageal hernia. These are the three indications we have in our department to ask for a CT. I don't think the barium gives, what I'm interested in the CT is, number one, is the RAP below the diaphragm or above the diaphragm? Number two, where is the OG junction? Is it below the diaphragm or above the diaphragm? And number three, what is the size of the crural defect? In case the crural defect is more than 5 centimeters, then we have an open mind about putting in a mesh at the hiatus. I know this is slightly controversial, but that's the policy that we follow.
Thank you. Any comments from other experts? Sri or Professional?
No, I agree.
Okay, thank you. So, so what do you do generally, Dr. Patankar, if you suspect the RAP is migrated? What is your aim of planning to cure this patient?
So clearly, if patient is symptomatic, now when you say patient has come back with symptoms, are these new symptoms or they were the same symptoms that he had prior to surgery? And if you look at the Lotus study, I think it's important that almost 30% of hiatus hernias who have a problem will develop new symptoms of chest pain or dysphagia or bloating. So if I can correlate the RAP migration with the symptoms, I would do a CT and then offer him surgery. No question of that. I would not do a manometry in a redo surgery, because to me, anatomical RAP migration, if there's correlation with symptoms, I see no reason to do a manometry. Most times the manometry is fallacious in this situation.
Thank you. Mr. Kadikamanathan, what are the types of RAP migrations and your views on planning of next steps?
So in terms of RAP migration, Tom DeMeester again classified this many years ago, type 1, 2, 3, and 4, but predominantly they are type 4. I mean, if 80 to 87%, I mean, I think one of the studies showed is type 4. In other words, the RAP goes into the chest. The other forms of RAP migrations are rare, to be honest. So I think I would again do a CT in this particular patient,
Yeah. So is it, during surgery, if you suture, both sides of the RAP to cross, will it prevent migration, Mr. Kadikamanathan?
It's $1 million question. I think a lot of people do this, but still RAP migration happens. So there's no way of, unless you do a randomized study showing half stitched and half not stitched to see what happens. But you can't tell. I mean, if migration happens, is the end game, isn't it? Yeah, in this particular case. Does suturing prevent it? We don't know. It makes us feel good, but does it really prevent it? We don't know for sure.
So I think RAP migration is due to a lot of factors. I think one of which is just anchoring the RAP to the crust. It is the posterior mediastinal dissection to lengthen the esophagus how well you close your crura, how large your window is the patient retching or vomiting immediately after surgery? All these are factors. It's simplistic to think that you can just put a couple of sutures anchoring the wrap to the crus and prevent migration. Life doesn't work that way.
Professor Nath, what is your experience on this?
Yeah, no,
putting
I do fundopexis, but I take colleagues. See, the operation. There are 5 principles, including esophageal mobilization of 6 to 7 centimeters, plus or minus short gastric division, optimal closure of the crura, and of course, consideration of positioning of the wrap and the type of wrap. And I do add, fundic sutures to the crura. Obviously, in a revisional case, I put a mesh as well, so which we could discuss later. So I think there's so many factors, and touch wood, at least personally, in the last 12 years, I haven't had a wrap migration, although I had recurrence, if that makes sense. And I do deal with a lot of revisional cases, and recently started doing these robotically as well. So it's interesting, but there's a lot to learn and a lot to make our patients' life better.
Thank you. Manjula, I think working in a very high volume center in Singapore, doing this type of anti-reflux surgery. So what is your experience on wrap migration in your center?
To be honest, I have no much of experience in wrap migration. So basically primary surgery.
Right. Thank you. So because, doing a proper surgery is the main technique, I think. But, when we do come across this kind of situation, it is, we have to do a, MDT approach. That is the message we want to give. So that is, like if we don't see much, I think we get together and do and accommodate. Planning is the most important thing. That is the message we want to give. Because surgery is not the sometimes best decision. So if I, see the wrap, if you look at this X-ray in the barium images, you can see, wrap is intact, but it's migrates to the chest, the video, I think. Yeah, so this is the, CT scan image, I think, of the, wrap. So you can see, so it's important to, discuss the CT scan in the MDM and plan properly rather than, just jump and especially Dr. Patankar mentioned, everything is depending on symptomatology rather than, just we should not treat these patients CT scans. I think we ideally have to go through patient symptoms and then we have to do it. So, Mr. Kadikamanathan, and this is the pH and impedance study which did this patient. Is very interesting. The Dimester score is 0.45. Distal acid exposure is 0% total times. Number of reflux episodes were not increased by impedance of determination. Symptom SAP and symptom index both. So indicate gastroesophageal reflux of PPI. Patient actually having nighttime significant reflux, and it's a volume reflux basically. So in this type of difficult scenario, what?
Sorry, I think the key thing about this is that patient's got an intact fundoplication, so won't have reflux. The problem with nighttime reflux is that because if you think of the stomach as a part of the stomach has gone up into the chest, and therefore you have an hourglass kind of stomach. So there's a small gastric reservoir containing acid, and that can cause nighttime reflux. I think it's been shown many a times. It's nothing new. One of the things I'm looking at is the manometry actually shows pan-esophageal pressurization, in my view. And there is fluid column in the esophagus, and I really can't see the lower esophageal sphincter completely relaxing. Okay, the pressures are not high, but I don't think it's relaxing. Has the patient got dysphagia? Do you know? Or
Sorry, Sri?
did the patient complain of dysphagia?
No, patient has no complaint of dysphagia.
That's
So
interesting because
when he
it's
lies
almost
down,
like a fluid column in the esophagus. It's particular.
food is amount. That is the complaint.
Okay.
And even, peristalsis was failed.
That's difficult to, I mean, did they induce, you got rapid multiple swallows as well? Yeah. I mean, that's neither here nor there, actually. I mean, sometimes, patients who have got very poor esophageal peristalsis after fundoplication, their peristalsis gets better. So it's neither here nor there. I think, as Mr. Pataka said earlier on, in some ways, the sort of recurrent kind of cases, manometry and pH are less important than anatomical issues here, so.
Any comment on from Dr. Patankar? Any comments on this? These are difficult cases, isn't it? So
I don't really buy this manometry. I don't see the LES pressures here. So I would first not do a manometry because, see, if you look at the CT, there is a radiological classification for RAP migrations called the Hinder classification. And this is a 1B Hinder. That means the OG junction has gone up and the RAP has gone up. So the esophagus is probably a little bit shortened and it's pulled the RAP up with it. I cannot believe that a patient who 6 months ago had normal body motility will develop absent esophageal motility. Simply not possible. You don't develop a achalasia after surgery. You may develop a pseudo-achalasia because of a tight RAP, in which case your LES pressures are high, but the body motility will still be seen. If you have done multiple rapid swallows, I suggest you repeat the manometry. I don't buy this manometry. And I would have not done a manometry. I would have taken the guy back to theater after a CT.
I entirely agree. It's very fallacious, and manometry, Chicago 4 is more confusing than Chicago 3, which is more confusing than Chicago 2. So he has got a structural complication as long as you sync them with the symptomatology and it's and how his life is getting affected. You get on with cross-sectional imaging, and I'm sure if you repeat the manometry tomorrow, it will be different than what it is today. So I concur with what Dr. Patankar said. So yeah, he needs revisional operation.
thank you very much. And it's a very difficult case. So we get two questions from the audience. And is there a place for, they have asked, is there a place for routine barium sallow in initial evaluation from expert? Anyone can explain?
Well,
No.
In UK, access to pH and manometry because of COVID has significantly affected. So therefore, we routinely do, in addition to pH and manometry, barium examination, and occasionally, if there's any stasis across gastroesophageal junction, especially the transit time between the gullet and the stomach, it just gives us a bit different perspective. That's the only reason. The barium is not to diagnose reflux. Barium is just as a guidance. And of course, if you've got a big hiatus hernia, you would see it anyway, irrespective, especially when you're doing cross-sectional imaging. So it is not for diagnosis of reflux. It's just as, and we do give two components. One is just liquid barium. Other one is like a solid component, like marshmallow or a bread coated. That just gives a bit of an inkling to the surgeon, especially when you do it. When you see the fluoroscopy part of it, that's the only reason. So obviously, I'm sure all of us do differ in our own approaches.
Thank you. Any comments, Dr. Patankar, from
So
you?
never barium swallow except when I suspect a shortened esophagus. I would do a CT when I see a giant hiatus hernia, a paraesophageal hernia, and prior to every revisional surgery. In my hospital, we don't think barium is very useful for hiatus hernia surgery.
Okay, thank you so much. There's another question. Is there a place for Colles gastroplasty?
Yes, there is a place, and I do a couple of colis every year, not many though. Just 18 months back, I did a 4th revision for operations elsewhere, and it's difficult. And of course, there is a place, but not for everybody, especially if you're planning for it. I don't recall me doing colis for a primary surgery, but in revisional cases, I have done.
So I completely agree with Professor Vishwanath. I think we would do a colysis only when the intra-abdominal length esophagus we can't get is more than 5 centimeters. And I think if you do adequate posterior mediastinal dissection in a primary hiatus hernia, even a giant hiatus hernia, you can always get esophageal length. The worry is 2 kinds of patients. One is the revisional surgery. And the second, we get some patients who come to us after multiple stricture dilatations by the gastroenterologist. So these people have a lot of submucous fibrosis and some shortening of the esophagus. But we have, as Professor Vishwanath said, I've done even lesser than, I've done now more than 1,000 anti-reflux surgeries and a total of 4 colysis gastroplasties in the last 20 years.
Thank you. Thank you very much. And we had a very good upper GI discussion today. And all these experts, I think they did the job well. And, I think Sri Lankan and overseas trainees who joined gain immense knowledge, and they have spent a lot of time, and local experts from our side, Manjula and Sanjeev, and from Alsgbi, Professor Vishwanath and Dr. Roy Patankar, and Mr. Kadir Kamanathan, my trainer in the UK. So it is great pleasure, having you on live to enlighten our surgical community, surgeons plus may I ask, do the official vote of thanks.
That brings us to the end of the CME session. I would like to thank all the faculty who participated, both local and foreign, members of the Alsgbi, members of the Amasi, and my colleagues in Sri Lanka Association of Minimal Access and Digital Surgeons for putting up this effort and this wonderful CME activity. And I thank all of you who participated. I think you all gathered some knowledge and enjoyed the CME. And I would like to say a big thank you to our sponsors, Sun Pharma, for sponsoring this event. And hope to see you soon with another activity like this. I would also like to thank the team in the College of Surgeons of Sri Lanka, Chatusha and Amali, for helping us, and senior registrars for doing all the work behind the stage. Thank you very much. Have a good night.
Thank you very much. My pleasure to be with you. Thank you. Enjoyed the evening.